Good morning, good afternoon, and good evening, colleagues, once again. My name is Deepa Pokhrel, and I lead the Demand for Immunization team at UNICEF headquarters. I will be accompanying all of us for these two exciting days that we've lined up. But before I hand over to our moderator, Dr. Ephraim, for the first session, I wanted to touch upon a couple of housekeeping items. Today, we will begin with an hour of panel discussion, and we will discuss how we can secure the political commitment needed to ensure easy access as well as demand for vaccines in high risk and vulnerable population in particular. We will then have two back-to-back sessions, which will focus on rapidly sharing innovative approaches to building public trust and demand. These are both proven and which look promising. We will be covering the behavioral interventions and service quality today, and we aim to conclude at 11 a.m. Eastern Time. Tomorrow, we again have some exciting sessions lined up. We'll be starting at 7 a.m. and we will be focusing on managing of misinformation and how to do community engagement strategies. You may pose questions and comments on the Q&A tab throughout the sessions. Though we will, of course, not have a lot of time for discussions today, but we certainly will try to incorporate some of the feedback from the audience. We have got simultaneous translation facilities into French and Arabic. A globe should be visible at the bottom of your screen for those of you who want to hear it in French and Arabic. So please select the interpretation that you need. With that, let me hand over to Dr. Ephraim for the first session's moderation. Ephraim, over to you.
Thank you very much, Deepa and colleagues, excellencies, and ladies and gentlemen, all protocols observed. Good morning, good afternoon, good evening, wherever you are. My name is Ephraim Tekle. I'm the Chief of Immunization for UNICEF based in New York headquarters. I would like to welcome everyone who has joined this global summit to the first COVID-19 vaccine demand global event, which focuses on enhancing vaccine confidence and uptake through risk communication and community engagement among high-risk and vulnerable groups. This event, it aims to help mobilize a targeted effort and build a coalition on increasing vaccine uptake globally, and especially in key regions and countries where some priority groups are still very much behind on their vaccination efforts. I'm excited to convene this event, which will focus on our most pressing need at this very moment, which is getting COVID-19 vaccines into the arms of high-risk individuals in priority countries and overall improving coverage in COVID-19 vaccination. To begin with, please allow me to thank and appreciate and pay sincere appreciation for all partners who have taken part in conceptualizing, designing, developing, and delivering this important event for today and tomorrow. The task has been quite an arduous task that actually needed a lot of hands on deck over the last several weeks, and we've been able to mobilize a significant number of partners to take part in this work. I would like to thank all these partners, members of the Vaccine Demand Task Force, and of course our co-hosts with UNICEF, the Minister of Health of Ethiopia, the Federal Democratic Republic of Ethiopia, and the Government of Canada, who has agreed to be a co-host and who will be also making an opening remark later on. We have also forged an excellent partnership with the Geneva Learning Foundation, who has enabled us to harness insights from a diverse group of health and immunization practitioners across different countries. And just last Friday, we have had convened an event of 600 plus practitioners to discuss and identify best practices and really learn from actual practitioners on what are the best ways to promote vaccine demand and uptake. And today's and tomorrow's discussion will also have a continuation to deepen further engagements and discussion on key topics during the next month's event convened by Africa CDC on accelerating uptake of COVID-19 vaccines in the African continent. This morning, We'll begin with a roundtable discussion, which I am looking forward to moderate. We have an excellent gathering of panelists who will be shedding lights on the key political, technical, and implementation-related challenges and opportunities of raising demand for COVID-19 vaccine in high-priority countries. But colleagues, allow me, first would like to invite the Honorable Harry Sajan, a Minister of International Development of the Government of Canada, to provide his opening remarks. And his opening remark will be provided by a video recording where our colleagues will be playing right after this. Over to you, colleagues, to run the first video. We don't have
researchers, heads of agencies, and others who are working together to fight COVID and increase vaccine uptake. As we all know, the global supply of COVID-19 vaccine is no longer our biggest problem. Rather, it is vaccine distribution and low rates of vaccination in low-income countries. The reasons for this are many. They are varied, and they can be very localized to communities, from fears due to misinformation and concerns about side effects, to the drop in the perceived risk of the threat of COVID-19. All of these are preventing people from getting this needed vaccine. We hear stories of Venezuelan migrants and Syrian refugees unsure of whether they are eligible for vaccines, and of women in parts of Eastern Africa with less access to health information and unsure of the impact on their pregnancies or future fertility. But we also know that there are very good reasons to prioritize vaccination. Vaccines are safe. Vaccines protect against hospitalization, severe disease, and death. Vaccines decrease long COVID conditions. Vaccines reduce the risk of new variants. And vaccines reduce future social and economic impacts of lockdowns or closures. Clearly, vaccination is needed. The job ahead of us is to communicate in ways that connect with community concerns through trusted sources. Many colleagues here are already doing amazing work to make this happen, taking tailored approaches, working with trusted community leaders, spreading accurate and evidence-driven information, and targeting vulnerable and remote communities. But there are a few areas that need our concerted effort moving forward. First, we must counter rumors and misinformation through channels like social media. Second, we must engage healthcare workers as critical communicators to build vaccine confidence. For example, in Nigeria, polio vaccinators are leveraging their community relationships to advance COVID-19 vaccination. Third, we must address the thinking that COVID-19 is not a big threat anymore. Finally, we need to continue to build the evidence base while maintaining political commitment and momentum at the highest levels. That is why I'm announcing CanGive, Canada's global initiative for vaccine equity. Through this new initiative, Canada is providing $200 million in funding for a new initiative aimed at supporting vaccine rollout in 13 countries. This funding will provide $100 million for UNICEF to build up vaccine logistics, supply chains, and the health workforce, while also undertaking surge vaccination campaigns. Together, we can find the best path forward to find solutions tailored to each community, country, and region. Together, we can champion approaches to support countries in reaching the goals they set for themselves. And together, we can dismantle the barriers that are holding back people in vulnerable situations. So I'm looking forward to hearing more from this event and keeping the conversation going about increasing vaccine uptake and confidence. Thank you. Merci beaucoup.
Thank you very much, Mr. Honorable Sarjan, who have provided us these wise words on how we can improve vaccine uptake. And thank you so much for the insight on engaging communities further and on your marching orders on how we can really improve uptake of vaccines and build trust in communities. I want to use the opportunity to thank you on behalf of UNICEF and the global community who works on improving COVID-19 vaccine uptake for your generous grant, that 200 million that you have announced right now. There is a long-standing partnership and relationship between UNICEF and the Government of Canada, and we look forward to using this funding to build primary healthcare systems that are able to deliver COVID-19 vaccine through strong supply chain through strong demand generation interventions, along with our many other partners who are operating within the space of delivering COVID-19 vaccines and strengthening routine immunization programs. Thank you again, Canada. I would like to proceed inviting the next speaker, who is our co-host. This event is co-hosted by UNICEF, the government of Ethiopia, and the government of Canada. From Government of Ethiopia, Honorable Dr. Elia Taddese, the Minister of Health, will be giving us her opening remarks. Handing over to you, please.
Greetings, everyone, distinguished participants. It gives me a great pleasure today to be welcoming you to this virtual global summit on vaccine demand. I'm also honored to be co-hosting this session today with Honorable Minister Sajan, the Minister for International Development for Canada, as well as with UNICEF. We're very hopeful today's summit will bring a lot of experiences to help us bring more global commitment and momentum to push the global vaccine demand and rollouts, reaching vulnerable communities in our countries. I will share briefly our experience in Ethiopia in terms of vaccine rollout for COVID. We started rolling out the COVID vaccine in March 2021, when we started implementing it in a very stringent manner, prioritizing those most vulnerable, particularly healthcare workers, those older age groups and with chronic illnesses. In the first few months, particularly from March to November 2021, using our primary healthcare system, we were able to vaccinate around 5.1 million people. So the progress was not as we expected, particularly, of course, compounded by the supply challenge. But even after the supply issues were improved, we were still not progressing much. So we had to sit and decide what other approach we should use. And that's when we first launched the campaign in December 2021. With our first campaign, we were able to vaccinate 6.1 million doses. And then building on this and getting the learnings, we continued with our second and third campaign. Currently, we are undertaking our third campaign. And as we speak, we have rolled out 49 million doses overall, of which the total population at least vaccinated once is around 4.6 million people. And 34.7 million people have been fully vaccinated. So this has been a huge progress, and this was possible due to many reasons. One is, of course, through these campaigns, we had extensive communication and advocacy up to the lowest village level. And this was supported through media and social media communications, advocacy. There was extensive supply and logistics support, which was enabling to reach communities closer to bringing the vaccine closer to communities using our outreach teams. And of course, this was also possible because of strong political commitment, leaders engaging at different levels in this campaign, and also the stakeholder commitment. We are engaging civil societies, religious institutions and religious councils and other communities in helping us move forward. We are also focused on reaching more vulnerable communities like IDPs and refugees and those in more congregated settings as well. And this has really helped our progress. But this would not have been possible without the support of our global partners. The vaccine, availing the vaccine was being done through the COVAX facility, through bilateral support from governments. And then the delivery support was supported by World Bank and also the COVAX through the COVID delivery partnership. And this support was really instrumental in really achieving these progresses, and the extensive support of the development partners on the ground together with us, particularly supporting logistics, including several car rentals, which helped enhance our national supply chain system. So although it was a challenging process, with all these coordinated efforts, it was possible to really achieve a lot. And I hope this experience sharing will help us also move forward in other countries. And this has not just supported the delivery of the vaccines, it was also at the same time supporting our systems, particularly our supply chain management systems. So I hope we'll have really excellent time and discussion, and My apologies that I'm not able to join this live, but my colleague has joined here to answer any questions that may arise. And I wish us all a fruitful session. Thank you.
Thank you very much, Honorable Minister Dr. Leah from the Federal Democratic Republic of Ethiopia. It's a great pleasure to hear her insights, and Ethiopia is one of the countries that are making stellar progress, along with several other countries, which our colleagues will be speaking about. But we have seen the value and impact a political commitment can bring, and the value and impact of well-designed primary healthcare focused systems can bring in reaching more populations. Series of campaigns are needed, and of course, the mechanization that goes behind it. And thank you so much for Ethiopia for sharing this, and happy to see that the senior advisor of the minister has already joined the call to give insights if there are any questions. Colleagues, we are proceeding to our high-level panel, a roundtable discussion on a virtual basis to hear from very distinguished speakers who will be able to giving us their insights and guidance and their learnings from their engagement in advancing COVID-19 vaccine rollout in different continents across the world. But let me take a couple of minutes to set the scene for this roundtable. Now that the global supply of COVID-19 vaccines is no longer a constraint at this very moment, low-income countries and some low-middle-income countries face a significant challenge of promoting demand for vaccination and ensuring delivery of vaccine doses to high-priority groups. Coverage rates in most low-income countries hover around below 30% and significantly lower than the WHO target of achieving 70%, and in fact, lower than the overall global average. We know that immunization rates may even be lower in vulnerable groups such as the elderly, migrants, health workers, and rural communities. These are very unique groups that our usual systems in primary healthcare settings and our vaccine demand generation interventions do not necessarily reach, and perhaps they are not armed to do so. And it presents another challenge for us to be innovative, inventive in finding new ways of addressing these high-risk groups. At this moment, only 60% of older age population and only 75% of health workers have actually been vaccinated. To meet this urgent need to accelerate COVID-19 vaccine uptake, UNICEF, along with the government of Canada and the government of Ethiopia, have convened this global event with partners in the COVID-19 vaccine delivery partnership to rapidly identify innovative, scalable, proven, and promising interventions, which may address public trust deficits, public trust deficits, promote demand, and mobilize communities to be part of the solutions and emerge as a winner in this fight that we all are together in. But as we work to sustain a sense of urgency amongst the public, especially in the face of waves of Omicron variant infections that we are seeing these days and continuing new variants emerging, we must also sustain political commitment to ensure we reach the high risk and vulnerable populations with COVID-19 vaccines. To further this discussion and hear first-hand experience, we are joined by a panel, Ted Chaiben, the Global Lead Coordinator for COVID-19 Vaccine Delivery Partnership, and also another colleague, Dr. Ahmed Ogwel Uma, the Acting Director of Africa CDC, and Secretary General Fatimata Hilmia from Maldivian Red Crescent have joined us today. And above all, we have also been joined by Dr. Wilmela Jala, who is the Honorable Minister of Liberia. Please permit me in inviting them to present themselves. If colleagues, if you can confirm that 4 of the speakers are on the call.
They are. Just asking the speakers to put their cameras on. And
yes, thank you very much. I see Ted, I see Madam Himia. Hi, Ted. And Honorable Minister Dr. Wilmena Jala are also on the call. We see her video on. Thank you so much, Honorable Minister, for joining us. We look forward to hearing from you. And Dr. Ahmed, Acting Director of Africa CDC, a good friend. Thank you so much. I know you are on your way to the airport, but thank you so much for making the time to join us. We'll try to accommodate your urgency with this. I'll be going with one question for each of you, and it gives you the opportunity to reflect on some of the key contexts in COVID-19 vaccine demand issues. I'll start with Dr. Ted Chaiban, Global Lead Coordinator for COVID-19 Vaccine Delivery Partnership at the level of an Assistant Secretary General, who is currently leading the global effort to really improve coverage in high priority countries. Ted, as the lead of the COVID-19 Vaccine Delivery Partnership, you are seeing an urgent need to galvanize both political commitment and action to accelerate demand on the ground, and perhaps to ensure vaccines get into willing arms as the quickest possible. How did we get here, and what do we need to achieve with this global event? Will be the next question that I'll be asking you. But priorly, please let me know on what are the key issues that really encourage political commitment. You've been traveling across different countries, meeting presidents and ministers. What have you learned, and what actually drives vaccine demand?
Thank you, Ephraim. Can I confirm that you can hear me?
Perfect.
Excellent, excellent. Well, good day, colleagues. Thanks, Ephraim, for setting the scene so accurately, and thanks to the organizers of this important meeting, and for those who have gathered for this panel, all protocol observed. As you mentioned, Ephraim, the context of the pandemic has changed significantly since last year. When countries wanted the vaccine last year, it wasn't readily available, but we now have vaccines that are sufficiently available, and in fact, supply is outstripping demand. So our effort needs to be focused now on making sure that vaccines translate into vaccination, especially of high priority groups such as healthcare workers, the elderly, and those living with comorbidities and in humanitarian settings. But before I go into what we are seeing in terms of the urgent need to galvanize both political commitment and action to accelerate demand on the ground and ensure vaccines get into willing arms, I like that term, willing arms, let me share a few key figures on where we stand on COVID-19 vaccination overall, building on what you put on the table, but also in terms of reaching those specific high priority groups. Let me actually make the emphasis on the fact that progress is possible. When many of the low and middle income countries wanted doses in 2021, they were not readily available, and Omicron has changed risk perception. But nonetheless, the percentage of fully vaccinated people in the 92 advanced market commitment entities went from 28% to 46 in January to 46% now. Among the 34 countries which are at 10% coverage in January 2022, 10% or less, half have made significant progress, with countries like Central African Republic, Cote d'Ivoire, Ghana, Sierra Leone, Solomon Islands, Uganda, reaching vaccination levels exceeding 20% of the total population. And in the 31 countries in WHO's Africa region that are reporting on this, about half of the public health workers have been fully vaccinated, compared to just 1/3 at the beginning of the year. So progress is possible and has taken place, and it's important that we recognize this. And yet still more needs to be done. Among the 92 AMC countries, as you pointed out, Ephraim, that report data on vaccination of healthcare workers, 75% of the workers are vaccinated, but that drops to 58% when you look at the Eastern Mediterranean region and 44% in Africa. Among elderly, overall, it's 60%, but only 17% in Africa. So, we want to work together to make more progress to protect the most vulnerable in society. The countries that have made progress have done so through a period of vaccination campaigns to accelerate uptake, and the next 3 to 4 months are key. We need to support countries to first reach their country milestones when it comes to COVID-19 vaccination coverage, with a focus on high priority groups. So as we have traveled and engaged, it became clear that increasing vaccine demand and continuing to address vaccine hesitancy with a focus on high priority groups is still a key part of the strategy. This is why we actually asked for this demand promotion and risk communication community engagement meeting to take place. And from our perspective, it will usefully focus on 3 issues. Firstly, is addressing vaccine demand following the change in risk perception caused by Omicron. Secondly, identifying best practices to reach high priority groups. What are the strategies and channels to do so? And then thirdly, continuing the work on addressing vaccine hesitancy, especially among healthcare workers. To focus on both vaccine demand more broadly and vaccine hesitancy more specifically. On the first point, how things have changed since Omicron in terms of risk perception, and the fact that many people see Omicron as less severe and thus reducing demand for vaccine. How do we continue to have a dialogue around the fact that there are still severe forms of this disease, in some cases leading to hospitalization and death? We in addition want to protect against the next variant and the next wave. As we know, in most countries, most people, including among high priority groups, are willing to get vaccinated as long as it's an easily available, seamless experience. Hence the importance of decentralizing vaccine delivery, bringing vaccines to where people are and making vaccination convenient. Door to door, community to community strategies, which have been employed in a place like South Sudan, for example. The work done by Sierra Leone in reaching every healthcare worker by making the vaccination available at the workplace, using mobile vaccination units to reach far-flung populations. So there's issues of strategy. There's also issues of messaging when it comes to vaccine demand. Second, in terms of reaching high priority groups, we've moved in some ways from the overall, let's get our percentages up, to let's make sure we prioritize high priority groups. So what are the channels and messages? Community and faith-based organizations have a key role to play, as does civil society in reaching the elderly. In Zimbabwe, for example, the government worked with faith-based organizations to reach the elderly at their places of worship. And then this question has come up: can the young be a channel to reach and encourage the elderly to be vaccinated? And then last, this continuing work of monitoring rumors and misinformation and continuing to counteract that with targeted messages. I say last, not because it's least important, but because there's already a body of work on this that we need to build on. How do we work with community members, leaders that have a high level of trust with their peers, especially in urban setting and especially among healthcare workers, to address this? As has been done, for example, in Central African Republic, where the government worked with technical partners and professional association to track rumors, behaviors, and attitudes towards the vaccines. I think the good news is that many countries are taking steps to address this now, and I really look forward to hearing both from Ahmed and the minister from Liberia, as well as our colleague from the Maldivian Red Crescent. I really hope that this important gathering will help provide practical ideas and pathways to increase vaccine demand and address vaccine hesitancy as part of this critical push over the next 3 to 4 months to raise vaccine coverage levels, especially among high priority groups. Thanks, Ephraim.
Thank you very much, Ted. We really appreciate your guidance and insights and for giving us the overview of the current key coverage figures. It is really telling to see that how the demand is shifting given the impact of Omicron, whereby the risk perception has somehow went down. And it's very important for us to move from an overall coverage improvement to much more high-risk groups, so that we'll be able to also reach the other groups if we're able to reach high-risk groups first. And as you rightly stated, misinformation plays quite a big role, and there is a need to beef up our capacity to counteract this misinformation. Please permit me to go to Honorable Minister. If you could reflect on how have you been able to secure support from the national leadership, because we have seen one of the critical determinants of success is actually political commitment and engagement of the national leadership, particularly including international partners, to accelerate uptake of COVID-19 vaccines. We'd be very happy to hear your insights, particular to the demand generation efforts you have put in place in Liberia as well. Over to you, and I will bounce back later on to Dr. Ahmed to also give us the African continental level perspective. Honorable Minister, over to you, please.
Good morning to all, and I want to say thank you, Mr. Moderator, for having me on this program, other distinguished panelists, and all protocol observed. Liberia, like any other country, demand for vaccines, especially COVID-19 vaccine, will initially center around people seeing what was happening to others. So for example, during the Delta variant, when we had a lot of people with low oxygen rates, a lot of people wanted the vaccines. And at that time, we did not have enough vaccines in country. So I guess we lost a few people there, but overall, we were able to receive all of the vaccines that we need to vaccinate the rest of the population. So far, healthcare workers, we are 85% of our healthcare workers have been fully vaccinated. We are up to 66% of our national target of people being vaccinated and 43% of the WHO target. So a lot of our counties have reached the 70% mark. So we are very happy with the progress that we are making, thanks to all of our national, international, local, and our government for making it possible for us to be able to receive the vaccines and be able to distribute them all around. But overall, you need good leadership and guidance in order to do any of these things. Our president set up a task force called Sparkle that were able to meet on a bi-weekly basis to discuss COVID as well as the vaccine. We have an IMS that met initially weekly to discuss COVID, the vaccines and all the issues surrounding making sure our population was safe. And also we had meeting with churches, we had meeting with other political leaders, communities, or school, everyone were on board in terms of making sure that we have these vaccine rollout. Most importantly, everyone wanted either the electronic vaccine card or a paper-based vaccine card. So if you didn't have any of those two things, people did not want to take the vaccine. So once you were able to provide on-demand vaccine cards for the public, everyone were happy to, most people were happy to receive the vaccine. So we work with the Peace Corps, we work with other groups, all of our partners supported where we had the vaccines to be printed within the community. So as you get vaccinated, your vaccine card was available there. That way, you were not saying, where's my card? So with that kind of momentum, I think a lot of the people were able to go out or to be vaccinated. One of the other things that we did was we introduced, right in the middle of the COVID vaccine, we introduced Pfizer for the school-based children. And that took off very fast in terms of all of our communities, schools being vaccinated. We hope that as the US drop the age of the vaccine taking, maybe we will begin to discuss how we can drop the age even further from 12 years old. Now we had to build a community confidence. So messaging was very, very important. You have to be honest and factual and be able to combat any negative things around the vaccines. We had a slow start because right in the beginning of when we wanted to start the vaccine, that's when AstraZeneca was the only vaccine we had. And we had that whole issue about AstraZeneca. So we delayed a little bit, let the news die down. Then we begin as the news of positivity about AstraZeneca were coming out. Then we started. So political leaders, myself, and everyone, we went out and we took AstraZeneca. We said, see, we are okay. So it's an okay vaccine, come out and take it. So that's how we encourage people to take their vaccines. Now, we had to make sure that we had enough stock at all time. And we had to relate to the public on who delivering what stuff. The US, Germany, France, everyone were on board in terms of making sure that we had timely vaccines. The AU or the CDC, the African CDC, everyone supported us. And since our population is just about 4.5 to 5 million, we just had, we were blessed with our vaccines being there and being on time. We're able to thank them properly at the airport as we receive all the vaccine from COVAX. So now in country, we have Johnson & Johnson as well as the Pfizer. There's no more AstraZeneca. So we are doing very well with both of those vaccines being in country. Or lesson learned that we learned from, focusing a lot on the COVID vaccine, we learned that our primary vaccine suffered. So because we had to recruit so many vaccinators to go out to reach the most remote villages, we tied up all possible vaccinators. So therefore, people who need a BCG, TT, and all of those other routine vaccines, there were nobody to do it. So we have to make sure that we create a balance in vaccinators. Make sure that you have vaccinators that cater into routine, and then the vaccinators that are going out for COVID. But we're in the process of now integrating COVID vaccine into routine vaccines, and then bringing everyone up so that some of the emergency that we are having in terms of measles and other vaccines, we catch up and make sure that we are on par. We want to thank especially our EPI team, all our international as well as national partners, our president, and all those who supported Liberia to reach the point. I'm sure we will make it to the 70% mark as soon as possible, and everyone will be relaxed in Liberia. Thank you.
Thank you very much, Honorable Minister, for that very powerful message and really demonstrating the commitment of the government of Liberia. We've seen the great impact of strong leadership at the highest level possible, and availing on-demand vaccination cards, which really encouraged people to have the certification they need. And that honest messaging, as he told us, which is really important to build trust, is something that we have really taken quite out loud. And of course, now your effort to integrate is something that many countries are likely to follow. Thank you so much for sharing your experience. And if we have time, I'll come back with one more question later on. Let me please invite my dear friend, Dr. Ahmed, the Acting Director of Africa CDC. In previous discussions, we were talking much about on how we can bridge the gap between people who are interested to take the vaccine and actually the number of people who are taking the vaccine, which there was a significant drop. What are the things that Africa CDC have been doing in the African continent, which many of the things that we have been already aware, but aiming on supporting countries to address the pandemic from the beginning, whereby if you could share some examples on how this has helped accelerate uptake of COVID-19 vaccines on the ground, and how could we capitalize on the momentum to build strong and sustainable vaccine demand strategies across the continent that would go beyond COVID-19. Over to you, Dr. Ahmed, please.
All right. No, sorry. This is mute, and mute has become part of our,
yes,
of our challenges. And I do apologize that I'll be leaving for the airport shortly. So I think this conversation is very timely. And indeed, the challenges we are facing on the continent, on average right now, we're at 18%. And that is very far from our 70% mark. It means that we need to triple our efforts and use every avenue available for us to get these vaccines into the arms of the public. Willing public, as that new phrase has put it. So let me start with the challenges. A challenge is we should not forget, and I think both Ted and the Honorable Minister of Liberia has mentioned this, the lateness of availability of the vaccines. The vaccines have come very late. When someone is faced with the simple choice of, do I go and queue up for the vaccine, or do I take transport and travel for an hour to go get the vaccine, or do I continue with my daily economic activities? For many, many Africans, the choice is not a choice, because they go out on a daily basis to earn, and therefore going to do their economic activities becomes a priority rather than going to get the vaccine, especially in the presence of few reported cases. And I'm repeating, few reported cases, because testing is what will allow you to know who is having the virus or not. So this challenge is what we are facing on the continent. And we as Africa CDC, the Africa Union, our partners, we have put in place a few initiatives that we believe are going to change the trajectory of vaccination on the continent. One, let me start with the most exciting one, and that is the Bingwa Initiative. This is an initiative that is aimed at the youth. Bingwa in Swahili means champion. So we are looking for youth champions in each and every country. And those champions then become the driver of the new momentum to get not just the youth to be vaccinated, but also the general public. And these youth, Africa is a very youthful population. So we believe that when the youth hear from their fellow youth the importance of getting vaccinated, when we make the vaccines available in an easy and efficient way, we believe they will be able to take the vaccine. So the Bingwa Initiative is one key new initiative that we as Africa CDC and our partners, the Africa Union and others, UNICEF included, are driving into over the next few months. Second is we are now rolling out very actively our Saving Lives and Livelihoods program. This program is designed to support our member states on the continent to go out and expand mass vaccination campaigns. We have seen the challenge of the people coming to the vaccines. So now we are adjusting our strategy and we are taking the vaccines to the people. We are using every means available, including mobile units that will go to the markets and go to the religious places and go to the schools, etc., so that we get the vaccines to the people, and it becomes a matter of minutes to get your vaccine rather than a matter of hours. And when you're earning $1 or $2 a day, and then you end up using that $1 or $2 to take transport to go and get vaccinated, that is one person, it becomes an impossible choice. So we want to take the vaccines to the people using the Saving Lives and Livelihoods program as the driver. The third thing is we are now ramping up involvement of our political leaders. The AU Assembly in February did pass a decision that is asking the policymakers at the highest levels, these heads of state, to be the champions for a new drive to get our people in Africa vaccinated. And we are using that decision to support our ministers, to support our heads of state, to support prominent personalities within countries, to be the new motivation, the new momentum for vaccination. And we are doing this systematically, adapting to each and every country so that we can be able to get these public figures to actually generate new momentum for vaccination. Finally, is to utilize the opportunity of the rising cases to redouble the message that COVID is still here. And indeed, COVID is still here. And this is something that we need to keep on reminding our population that it is still here. Although conversation is changing to monkeypox now globally, COVID is still here. And depending on the health condition of an individual, it can actually, and we have seen even in new wave, that it is bringing down relatively people we thought were healthy, but maybe they had a hidden problem that the virus then uses to be able to break down immunity. We are encouraging people to see the numbers rising. We are encouraging people to stay protected, and we are encouraging those who have already been vaccinated to get their booster doses, because some got vaccinated right at the beginning of the campaign, and it is extremely useful that we get them to be boosted so that we remain with a well-protected segment of the population. Finally, Ephraim, let me add that the health security architecture globally has not worked very well for Africa. And we need to ensure that the discussions that are going on at the global level now around the revision of the IHR or the global pandemic treaty, this global architecture must take care of the main challenges we've seen during this pandemic. If that global architecture does not take care of the challenges and the lessons we've learned, then we'll end up with legal instruments that are not going to address the next big outbreak, epidemic, or pandemic. And as the Africa Union, we believe strongly that a key part of this is regionalizing public health emergency pronouncements and response. In this way, we have the strength of numbers, while at the same time we have the nimbleness of speed, because we are dealing with a smaller portion of the world. Waiting for the whole world to rally behind an event is usually does not allow for speed. And in any outbreak, in any epidemic, in any pandemic, speed is of the essence. As Africa CDC, we are committed to continue supporting our member states. So the coming months are full of speed, of vaccinating, putting vaccines into people's arms, and that will automatically generate new demand for the vaccines that are currently being manufactured, particularly here on the continent of Africa. I thank you for the opportunity and looking forward to the outcomes of the meeting. Thank you.
Thank you very much, Dr. Ahmed. We really appreciate your guidance. And of course, we have really appreciated the commitment of the African Center for Disease Control in providing this right set of guidance for countries. And you have been at the forefront of responding to the pandemic and rallying a political commitment along with presidents and leaders of countries in the African continent. We have heard quite out loud with the fact that taking vaccines to the people is the message. Having an understanding and knowing that actually people coming to the vaccine has a lot of opportunity cost, and the renewed commitment you are currently implementing through your SLL engagement is quite something to really appreciate. And we are all in agreement on the need to really shift the global health security architecture to be able to be localized. We have pandemics, we have epidemics, we have outbreaks that require similar level of engagement, even though their levels vary. So thank you so much for your reflection. In this round of reflection, the last but not the least, and thank you so much for the patience as I go around with each speaker. Madam Fatima Timea, Honorable Secretary General from the Maldivian Red Crescent. We would really like to hear your opinion about the role of local organizations like Red Cross and Red Crescent has been quite impactful in really reaching to those communities that remain unreached and in bolstering commitment for more vaccine demand in COVID-19 vaccination. In Maldives, what are the key best practices that you have seen in encouraging much demand and improving vaccine uptake and trust? We'd really love to hear from you about your experience and how you have been able to achieve that. Over to you.
Doctor. Thank you, Dr. Ephraim, for the opportunity. And I think to begin with, the first thing that I would want to highlight when talking about the role of local organizations, especially like the Red Cross and Red Crescent, is the trust and access to the most vulnerable people that we have in our communities. It is the confidence and the trust the beneficiaries and the people we serve as humanitarian organizations in our countries that is built over years of working with the communities that actually gives us that advantage over any other organization. And it is an advantage that Red Cross, Red Crescent national societies have over other local NGOs because we follow our guiding fundamental principles and we have a legal mandate in most of the countries to serve the vulnerable. As you would know, sometimes public confidence in government responses gets pretty low, especially among vulnerable groups like migrants worldwide. So when it comes to trust, when people don't trust us and the messages we give, they refuse to wear masks, to comply to social distancing, to self-isolate, and to use effective biomedical tools and services available to them. And in such situations, you're unable to provide the services that they're supposed to get in especially vaccination as well. So the success of the vaccination work depends on trust. Trust between citizens and their governments and local actors. And I will just add an example from the Maldivian Red Crescent into this is how we addressed the vaccination of undocumented migrants in our country, which was pretty much in agreement with the government. But we have about 60,000 and more undocumented migrants living in our country. And we partnered with the government and came into an agreement that the Maldivian Red Crescent will register these undocumented migrants for vaccination. And we protected their data, and we ensured the migrant population, their safety and security with us. At the same time, we were able to ensure that they had access to vaccination, which was done through the government vaccination centers. So it's also a partnership with the government, but also it's a partnership. At the same time, it's also the trust and confidence we have, with these migrants in our country. The second point I would like to highlight is the need to act fast, but also act locally and to continue to focusing on the most vulnerable. Again, most of the time, it's always the citizens of the country that comes to the forefront. And, vulnerable groups like the refugees, migrants, undocumented migrants and stateless people always are left behind. And I think like local organizations and humanitarian organizations like us, we are in the communities at the ground level. And that is where I think all the other speakers are highlighting where interventions need to be made, where awareness needs to be created continuously. It cannot be, a once-off thing. So we have to continuously move ahead with the awareness programs. We have to give the messages. The COVID-19 has been, the situation has been unfolding in a very unpredicted manner. So we have waves coming in, we have, normal times, and then again, we hear of cases increasing. So the need to act fast, when numbers are increasing, and currently as I speak in the Maldives, I've just heard that, cases are increasing because I'm out of country. But again, our volunteers are being mobilized, our mediums of sharing the messages are being again, increased because we know the cases are increasing. So this is the advantage we have. And I believe, again, which the government needs to support us more, being local organizations, this is where the resources needs to be put to reach out, to the people to get the message across. And I think finally, humanitarian organizations like us are able to reach the most vulnerable, through mobilizing these communities and through consultative processes. So in case of, again, migrants, we have difficulties and challenges like language barriers. They have a high illiteracy rate among migrants in our country. So they can't, even if we have communication materials, they cannot read or they cannot write. So we have to come up with mechanisms where we make sure that we get the message across to that last person or the person who we cannot reach. So I think, again, humanitarian organizations like the Red Cross, Red Crescent, and also many other local NGOs is the platform which needs to be used to reach to these people, to ensure that the messages gets across to them in their local languages. And we as Maldivian Red Crescent, we use migrant volunteers who goes out into these communities and talk in their own languages and, convince them and explain to them what the COVID-19 disease is about, what vaccination really means. We have a very huge percentage of people, migrants from Bangladesh, and unfortunately, they have lots of misconceptions around vaccine because they've heard rumors through different sources, and they were very hesitant at the beginning to get the vaccine. And we had to continuously target these groups to ensure that, they came forward. They were scared of getting vaccines. They've heard that they die, with the vaccination. So these are very illiterate groups of people because, in the sense of awareness, in the sense of what a vaccination would actually do to them. And we had to continuously, for months and continue with our advocacy and awareness campaigns to really convince them to come forward. And also, given their legal status in the Maldives, they were very hesitant to come forward. But I think just, one additional thing that I wanted to highlight regarding the beneficiary system, we had the registration system. We were able to register almost 5,000 undocumented migrants, and we were able to ensure that they were vaccinated. And I think just before I close my remarks, I think what's really important at this point is, the situation has changed in our country as well. At the beginning, we luckily had enough supply for vaccination. So about 90% of our country got vaccinated immediately within the first and second wave. But the reason why we were able to actually achieve this 90% was because we did not exclude the migrant community. Because like I said, if 60,000 to 120,000 population is migrants from a 400,000 population in our country, if we had excluded the migrants at the very initial stage, we would still not have reached that 90% vaccination percentage in our country. And the reason why today, better than any other country, I think even in the world, we were able to open up our economies. We were able to, allow tourists to travel back to our country. We picked up things quite fast because, the initial decisions made by the government to leave no one behind during vaccination was key to it. But the issue we are facing now, I think, is also concern, like other colleagues who have spoken up, is, the demand for vaccination, again, like getting the booster dose, is very low. I think not even 20% of the people in the country, though the vaccines are available in the country for free for everyone, including migrants, people aren't coming forward to get the vaccine. So I think it's high time that we all work together, especially with the government. I think especially the governments need to push this forward, because when the governments create that urgency, for the people, to come forward and get the vaccination, that's when it really starts working. And definitely, we as humanitarian organizations, we are always there to support in our auxiliary role to the government to ensure that, we support in this process. Thank you very much.
Thank you very much, Secretary General Fatima Himia from the Maldivian Red Crescent, and thank you for sharing the great work you have done in reaching marginalized populations, particularly migrants, who are likely to be undocumented and who will end up becoming not being part of the system. But having, living in a country whereby 25% of the people are migrants who live in that country, a focus on such population is really an important aspect of improving coverage and building an overall immunity in the country. An excellent job on that. Thank you so much for your reflections. Colleagues, we have a few minutes to just open up for questions. I know Gloria has been the one coordinating the questions, but we are also seeing so much interaction on the chat. We are joined by close to 450 people already on the call. I'll invite Gloria to be able to coordinate on who asks the questions.
Efren, this is Silvia Magnoni. I'm the Global Coordinator for the RCC Collective Service. I've been monitoring the Q&A and the chat together with Gloria. So I will maybe take a couple of questions and put them back to you, Efren, and then you can allocate and distribute to the panel, as I think we have a few minutes for picking those questions. I was monitoring the Q&A very closely and definitely see a lot of interaction there. I think, we have seen questions that are really more in relation to some of the difficulties that we were just discussing about and that we're still experiences in terms of low risk perception, a low perception in terms of diminished effectiveness of vaccines, some of the logistical issues in terms of vaccine delivery. And I think actually that the answer to some of these questions, we will will aim throughout the course of this event to actually tackle them in more detail. But, starting from some of these difficulties and trying to put them also against the big picture of the fact that actually countries and people are experiencing COVID as part of a bigger context when there are concurrent crises, when there are other public health emergencies, when there are other, disasters and conflicts in place. So how do we actually ensure that we keep the highest political momentum in the next few months, that we actually generate a very strong joint advocacy effort so that we can really achieve that target in a collective way? That would be one question. And then a second question, which I've seen going through also in the chat, is it's good that the international community comes together and that we favor different type of partnerships and relationships, but really how do we tap into the knowledge and the expertise of local NGOs and local actors, those that really know also the type of marginalized and disadvantaged communities that they have in their territories. So how do we actually involve them more in the work that we have ahead and leverage really their expertise and knowledge and influence going forward? So I'll have these kind of two questions, which don't seem, can be very open in terms of answers, but I'll leave it over to you. And if we have time, happy to take more. Over to you, Ephraim.
Thank you very much, Sylvia. That's very helpful. I'll just tweak these questions to use the opportunity to ask the panelists to give us their final messages with regard to increasing political attention and commitment in reaching the unreached. And I would start with the Honorable Minister. What is that one thing that will need to be done to really advance in reaching the unreached in COVID-19 vaccination, particularly those high-risk groups? Just one thing.
Well, I think we have to get the head of state in the community himself to, he doesn't have to give the vaccine, but he have to be present and talking with us while we reach the more vulnerable group. I think that will help. I think people want to see that highest level of leadership in the field talking about vaccines.
Excellent. That is a vote of confidence, definitely. Going to Fatimata, what is that one thing that we'll need to do to reach the unreached? And you have done this well already.
Well, I think, Dr. Ephraim, it's the continuous, advocacy and continuous awareness that we continue with. And I think currently people don't see the need to get vaccinated anymore because the idea and the notion of that, we don't have COVID amongst us anymore is very significant in all countries, I think. So I think it's, we need to put some urgency into the matter, saying that, and all governments and all, organizations and humanitarian organizations working in this to highlight that, it's not over. It's not over, and that we need to continue with this and the vaccination process and also getting the booster vaccination. But of course, there's lots of misconceptions, as I can see, comments coming in. We need to address those misconceptions. And, if we don't address those misconceptions at this point, we would not have any increase in demand for vaccination by the public because everyone is now comfortable, where they are. So I think we need to continue with the advocacy and the awareness.
Thank you very much. We don't have time. Sense of urgency is very important, and we don't have time to be complacent. Excellent. Ted, please, your final messages on this. And then I'll invite my dear friend and colleague, Kate O'Brien, Director for the IVB Directorate in WHO, to give us a concluding remark as a marching order. Over to you, Ted. Your final messages on this issue.
Ephraim, thank you. Let me focus on the elderly to complement what the Honorable Minister and what Dr. Fatima have said. Really work in a manner that vaccination is accessible easily next to your home, and that we work with local political, community, and religious leaders to access and work with the elderly, including associations that focus on the elderly. This is really, I think, the biggest challenge in terms of reaching the most vulnerable. And let me again say how important this meeting is and how critical it is to keep attention on COVID-19 vaccination, and use the opportunity of the next 2 to 3 months to raise vaccination levels, especially among high priority groups. Thank you, Ephraim.
Thank you very much, Ted. I'll come back after a conclusion by Kate, just to give a hint of what's going to happen next. Kate, please. We're trying to be in the same room so that this meeting will happen at least in a big gathering. Huh?
We're just trading seats here. I am so pleased to be able to be with you, just to make some concluding remarks after really, active conversation. So we've heard that this is a really challenging context, and many factors have hampered the uptake so far. First of all, the delay in supply, let's call that the late delivery of vaccines, misinformation, challenges in scaling up delivery, especially in these age groups. And then outreach to the most vulnerable. And we knew that these were going to be challenging things, and indeed they are. But we've also heard about some of the actions that can really help turn this whole thing around. And those are, number one, actions that demonstrate political commitment. And I just love the reflection just at the end here. We need the head of state to be actually in the community, supporting, present at the time of vaccination. Ways to engage youth and other partners, and the importance of making vaccines really accessible to people at the time and the place that's convenient for them. And also the importance of taking vaccines to the people through a mass campaign approach that is tailored to those who are most in need of the vaccines. And that includes providing booster doses, because we do know that that's a critical part of an effective vaccination schedule. We've also heard that we're at a really critical time now for COVID-19 vaccination, and we have to capitalize on this now. It's this moment that we really need to move on this. Now is the time for action, not 6 months from now, but right now. So I'll add just a few reflections to build on the discussion that's been had so far. We've already been living through this pandemic for 2 years. This is now a chronic crisis, and learned that a failure of equity and access has really terrible consequences, humanitarian consequences, because of without equity, we know that deaths will rise. Economic consequences, because without equity, the global economic costs of the pandemic will continue to grow. And biological consequences, because a failure to control the pandemic risks adding new variants and new waves of disease that circulate around the globe, and that will undermine the efficacy of the existing vaccines. So in working with partners, we've seen many examples now of what actually works to increase vaccine confidence and uptake. And these, I think, we can summarize by saying, first and foremost, listen to and partner with communities, their representatives, and with civil society, religious leaders. Make vaccination services as easily accessible as you would want them, and as affordable. It should be a positive experience. We really know that the positive experience somebody has is a cycling event and results in more uptake and more demand. Make accurate information easily available and culturally appropriate so that people can take it on board. Offer behavioral defaults and nudges to remind people of when and where to go. They're very busy, otherwise this is not top of people's minds. And use local data on behavioral and social drivers to inform the strategies that are being used. And all of this requires attention and investment of policymakers and decision makers, many of whom are on this call now. The related sort of structures and capacities and partnerships need to be established if they're not already. The health workforce needs to be supported with the potential to then benefit primary health care, and prioritized populations, those who are at most risk of having a severe consequence from a COVID infection, really have to be the crucial focus right now. So in the remainder of the event, both today and tomorrow, we'll hear about 20 different approaches that could help accelerate COVID-19 vaccine uptake in your country. And these approaches will offer us new ideas and insights about implementation of programs in an effective and equitable way. And to do this, we need all leaders, all of you as leaders all around the world, to drive investments in and support for immunization. And the reason is it's urgent that we close the equity gaps for COVID-19 vaccination. And this will impact on health and human development for decades to come. The moment is now, and the resources are available to take action and to actually move this program. And so I'm really, really excited about the convening, both today and tomorrow. And I'm very pleased to have been able to close this session. Thank you so much.
I'm back for the last time on this high panel. Thank you very much, Honorable Minister, Honorable Fatimata Himia from Red Crescent, and my good colleague and who is leading the global COVID-19 vaccine delivery partnership, and Dr. Kate O'Brien for making the closing, sharing the key messages. I think we have heard it. We have heard it clearly that leadership, focus on marginalized groups, and not being complacent are the key issues that we need to face. And COVID-19 is not over yet. In these discussions that will follow this high-level panel, so many detailed issues will be discussed. We'll talk about innovations on behavioral change. We'll talk about community engagement. We'll talk about health service delivery related demand generation activities. And we'll see from different colleagues and experts who'll be able to make a presentation over the next 2 days period, which will definitely start right after this high-level panel. Please permit me to thank on behalf of UNICEF and our co-hosts, the government of Ethiopia and the government of Canada, and on behalf of the team that put all these things together, and on behalf of the participants, 450 participants we have on the call, who have been able to join us from the start of this high-level panel. Thank you so much. Thank you. We really appreciate it. And we look forward to hear the output of this deliberation, and we look forward to following up the outcomes. Again, thank you very much. And I will hand it over to the moderators, Gloria and Deepa. Over to you.
Thank you, Ephraim, for moderating this session, and thank you to all the panelists. So, colleagues, we will be taking a 5 minutes break, and we'll come back for the next session on the experience hearing from the countries. So it's now 8:14. If we can come back at 8:20, that would really be great. See you soon, colleagues.
Greetings, everybody. My name is Dan Irvin. I'm the Senior Director for Health and Nutrition for World Vision International. It's a great pleasure to be with you today and a great honor to have the opportunity to facilitate a very important discussion about demand creation for the COVID vaccine. Our session today, as you can see on the screen, is proven and promising behavioral interventions to increase vaccine demand, translating evidence to action with emphasis on high-risk and vulnerable groups. This panel today is going to share insights and learnings on how to translate evidence into action with emphasis on these high-risk and vulnerable groups, including health workers, the elderly, refugees, and people with comorbidities. However, at the same time, I think you'll find through the presentations that the approaches that our panelists will be speaking about also address greater population coverage in rural areas and just trying to get populations to accept the vaccine, addressing vaccine hesitancy issues in particular. Our previous speakers highlighted very important phenomena that we're going to be addressing in this session. And I note that Dr. Fatima said, this pandemic is not over. And Kate O'Brien noted that we're now dealing with a chronic disease situation. The evolution of the pandemic over the last 2.5 years has evolved from perception of a high-risk situation to a low-risk situation. And this now requires even greater innovation and targeted interventions to increase confidence and the acceptance of vaccines. Whereas previously our situation was high risk, the pandemic spreading rapidly, fast transmission rates. Now our populations globally are settling into a mind frame of the pandemic somehow receding behind us. It's being less urgent. And where they had some vaccine hesitancy earlier, it's being reinforced by these perceptions of the receding of the pandemic when actually it's not. And so we have a new key challenge before us in terms of how we motivate people to get vaccinated if they feel and think that they are not or are no longer risk of infection. Our presenters today are going to share innovations on how we can address this particular challenge, as well as the consistent challenge of demand creation and addressing the issues surrounding vaccine hesitancy. So we have as our speakers on this next panel, Martin Nvouros, who is an associate professor from Wageningen University. He'll be speaking about his experience in research in Sierra Leone. Martin will be followed by Chima Onwekwe, who is with the World Health Organization in Tanzania. Following Chima, we will have Dr. Chizoba Wonodi, who is with Johns Hopkins University International Vaccines Access Center, speaking about their research in Nigeria. And finally, in closing the speakers, we will have Faisal Khalil working with UNICEF in Pakistan. Each of our speakers is going to be sharing with you very unique approaches that they've taken towards addressing vaccine hesitancy and demand creation in these very interesting contexts that they've been working in. Now, again, my greetings to all of our participants around the world. Great pleasure to have you all with us today. We look forward to your questions. We're going to take your questions following the four speakers. So we'll have the four speakers first, and then we will have quite ample time for some discussion. So we ask you to place your questions in the Q&A platform. You can find the link for that platform at the bottom of your screen. Our session here runs to 9:40 Eastern Standard Time. So we have, give or take, 75, 80 minutes for the presentations and the discussion. So with that, I have the pleasure of handing over to Martin. Martin, welcome to you. Thank you for coming on and sharing your experience in Sierra Leone with us.
Thank you, Dan. And very nice online to meet so many of you and have the opportunity to talk about our work. I'm a development economist studying questions on often that relate to barriers in the process of development, and they often relate to important technologies that are definitely welfare enhancing, but are still not adopted. And we're going to focus here on a randomized controlled trial that we just completed in rural Sierra Leone, where we took that question at heart to understand better what those barriers are. So next slide. So briefly to sketch the problem, and it's gonna not dwell too long on that because it's points that were made eloquently today as well. But the starting observation, of course, is that vaccination rates in many low-income countries are low. And often people, when asked about the reasons why, mention three different things. One is that we're producing vaccines, but we're just benefiting the wrong people. If you want to get vaccines rates up in Africa, we should just be sending more to them, and we'd be just prioritizing different things. Second question is, well, if we bring them over, maybe what happens is that people don't want them because the hesitancy is very high. Now, in a recent project that we did when we were asking people, so if the vaccine is available, would you take it? And this wasn't just in Sierra Leone, but we were comparing this across 12 different low-income countries. In fact, it showed that vaccine hesitancy was very low. Over 80% of people would say they would take it. And in fact, the acceptance was much higher than compared to the US or other large economies. So there's the third reason. If it isn't the top two, and we've heard about that vaccine supply has increased a lot over the later parts of the pandemic, then it must also relate to last mile delivery challenges. If we then take the case to Sierra Leone, where we've heard statistics earlier that 20% of the population or more than that have been vaccinated, but most of them live in urban areas. In rural areas, really hard to reach places, it's just 6%. At the same time, 88% are willing they would take the vaccine. Now, vaccines are regularly available at clinics, but it takes a rural individual 3.5 hours to get to a vaccination center, and it would cost about $6.50 one way. People want to get vaccinated, but potentially not that bad when the margins are so small, when people are so poor. So it's clearly an issue here. Can I have the next slide? So what we did is, let's put that question to the test, if you will, in a partnership with the Ministry of Health in Sierra Leone, with Concern Worldwide and our academic colleagues at the International Growth Center and Yale University, designing a very simple cluster randomized trial in 150 communities, where 100 communities were randomized to increase access using mobile teams, which engaged a couple of steps where we would be meeting with leaders in each communities, and at a community meeting, socialize the idea of vaccines and provide reliable information that often in rural communities is not present. Installing mobile teams. This means packing vaccines on the back of bikes together with nurses, and then organizing a temporary clinic, which usually ran between 48 and 72 hours, requiring administration, requiring registration. And then in addition, have additional outreach beyond the community meeting for people that may need more individual convincing. We had individual outreach, so knocking on doors of individual households and have private conversations there, of social mobilizers, or meeting people at fixed points. And what I mean there is youth working at the farm or women going to collect water. Just get a sense of if that would draw out larger numbers, but also potentially different populations. So we then primarily assess the effect on that and the vaccination rate of the eligible population in communities. Next slide. So this 48 to 72 hour intervention brings up the baseline rate from just 6% to about 37% in a very short amount of time. So this increase is beyond most existing studies in terms of vaccination rates. There's slight differences across subgroups. So the impact is larger for men, as you also see from other studies, and it's larger for other vulnerable groups, particularly the elderly. And there's sort of a secondary effect also, or maybe that's a mechanism more on people's knowledge of vaccine and their attitudes towards them. So then to round off what this teaches us, it's in a sense a proof of concept, right? So we can get large numbers vaccinated, even in these very remote and rural areas, quickly and cost effectively. But the lessons here extend beyond what we can learn from COVID-19. There are many other places where uptake is very low, and we should be thinking about these entry barriers or these last mile challenges more productively. And future pandemics will happen more. So the reason now is to learn about and invest in increased preparedness. The questions here, of course, related to scale up, both nationally as well as in nations that face similar challenges. And to further think about the cost effectiveness, what we observe here is that the variance within the teams is large. The average I'm presenting here of a jump of 27 percentage points, but the variance ranges from some teams getting 0 uptake and some teams getting 80% uptake. So we should be thinking more about what makes teams function better in the field. And we should be, of course, as mentioned eloquently earlier, address information issues. Now, in terms of looking forward beyond this, I think this is a clear case for advocacy with partners like UNICEF, the government of Sierra Leone, but also it paints a very clear message, right? The days of hesitancy are really far from, are really behind us now. Hesitancy and last mile delivery challenges are not a good excuse to withhold doses to rural populations. I think the message locally is to invest in these creative last mile delivery infrastructures, both here and in similar places. Thank you very much.
Martin, thank you so much. This is a very succinct presentation on a very compelling activity and piece of research that you've conducted. And we could say maybe a little provocative in regards our discussion on demand creation in terms of your assertion that getting the vaccines into the rural areas that are hard to reach really facilitates the uptake with the addition of some engagement of the population at household and fixed point level. I love what you're saying about hesitancy not being an excuse for the distribution. Very interesting. And so I look forward to people's questions around what you've very succinctly presented there. We can move on then. We'll come to those questions and discussion later, but we'll move on quickly to Chima Onwekwe, who's going to be speaking about the experience in Tanzania. Chima, you're very welcome, and I turn it over to you.
Okay, good afternoon, colleagues, and I want to very strongly appreciate this opportunity to share the experience of how we're translating evidence to action, an event-based vaccination approach in Tanzania. Next slide, please. For those of us who are very familiar with the COVID-19 history in Tanzania, you will agree with me that about this time last year, COVID-19 was like a forbidden topic in Tanzania. You can't really talk about it, not to talk of taking any action to get vaccinated. As a matter of fact, Tanzania is one of the few countries that did not introduce any form of health restrictions during even the peak of the infection. And as a matter of fact, only 7.7% of Tanzanians have received any form of COVID vaccination. Vaccines are available across the health facilities. Tanzania has got over 7,000 health facilities that are offering COVID-19 vaccination, yet utilization is very low. Information environment did not present or position COVID as a very urgent and very serious disease to raise the perception of people. Social norms around vaccinations are poor generally, and so studies have confirmed that people knew where and why they should get vaccinated. As a matter of fact, awareness is very high, knowledge is high, as much as some studies even quote as high as 93% are aware of COVID-19 vaccinations and know where to get vaccinated, yet they will not get vaccinated. As a matter of fact, the latest study that we have on the screen here has it that 71% of Tanzanians are willing to get vaccinated, yet only 7.7% have been vaccinated as at 20th of June 2022. Next slide. So what did we do? So we started looking around and thinking out of the box that what could be the problem, because there is inconsistency, there is a mismatch between what research findings are saying and what we see at the health facility levels. So we thought of taking the vaccines out of the health facilities and looking for people wherever they are. So we started to leverage, starting with a very highly visible event, such as football games, such as social-cultural events, such as in some other locations where people gather, so that we see whether some people who know and understand the importance of vaccination, but will not go to the health facilities, whether they will want to get vaccinated. So the football event provided a very good opportunity for us, because it provided opportunity for us to promote. We all do know what sports mean to the whole world, especially football. So this provided an opportunity for us to promote COVID-19 vaccination messages. We developed the rolling sleeves gesture as a symbol for vaccination support. And we partnered with match organizers to offer free tickets to those who will get vaccinated. Compared to event-based vaccination, the number of persons who are being vaccinated at health facilities across the country per day sometimes could be like 7 persons, sometimes could be like 10 persons at the maximum. But when we take one team to football events, we see that sometimes as much as 90 persons, in some locations, even 200 persons get vaccinated just in one event. when compared to vaccination figures that we get from the health facility. So we carried out interviews and focus group discussions to ascertain the barriers to health vaccination, to vaccination at the health facilities. And one of the persons interviewed actually told us that though I am willing to get vaccinated, but going to the health facilities will not only waste my time, but also will require that I have to spend some money for a disease that I don't feel anything about it. So why should I actually go there? Except you bring this to me, I am not willing to go to any health facility. Next slide. So the outcomes are: one, we successfully leverage media visibility around football matches and players as advocates for vaccination. We got about 990 visibility materials, 106 mentions produced and amplified on radio and other channels, including social media. We delivered key messages in support of COVID-19 vaccinations at 8 football events and got about 661 persons vaccinated at the football games. So we compared the number of persons vaccinated per day in the football events to the number of persons vaccinated at fixed health facilities for same day, and the difference was so huge. Key lessons learned here are that event-based vaccinations can be successful, especially when combined with health facilities, because we're not actually saying that this should be a substitute, but we're saying that they can actually complement the health facility-based vaccination as well as mobile outreaches, especially in settings where complacency towards vaccination and lack of convenient services and lack of supportive social norms are very high. And event-based vaccination provides highly visible events like with a lot of media mentions, because it provides us with opportunities to promote COVID-19 vaccination, especially for public communications on vaccination and for engagement of key players, key influencers who are football advocates. So for future research, we are recommending that there is still need to conduct in-depth interview to find out why some persons who know why he should get vaccinated, who understand where he should go get vaccinated, will still not do that. But when vaccines are provided for him at event locations or at some other locations that it is convenient for him, he willingly accepts to be vaccinated. Next.
Chima, thank you so much for that very innovative sharing.
Anyway, this is the end of the pitch, and I really appreciate this. Yeah, thank you.
Thank you very much, Chima. We really appreciate the innovation that you've shared in Tanzania. I like what you've said at the beginning about taking vaccines to where people are, and in particular based on their reluctance to go to health facilities, or the challenges that we've been hearing about in regards going to health facilities logistically. So this is a very interesting campaign on rolling sleeves in Tanzania, which I think a context which we've all appreciated as having special challenges also in terms of the public support for pandemic address and the health issues there. I would like to ask you to think about, as we come to our questions later on, whether you have seen an impact of the events approach in Tanzania on a wider population uptake, whether the events approach has created any momentum beyond the events. In other words, if you can think about that, and we'll talk about it later on. I'd like to invite all of the panelists also to come into the Q&A platform and feel free to share your thoughts about a series of questions we've been noting there in regards the synergies between the COVID-19 vaccinations and routine vaccinations, routine child vaccinations, or other, what you have experienced in your context in regards those synergies, positive or negative, and your outlook on the opportunities perhaps to leverage routine immunization systems, platforms, campaigns for greater COVID vaccination as well. So with that, let's move over to Dr. Chizoba Wanodi to speak about the experience and the research in Nigeria. Dr. Wanodi, I welcome you. It's great to see you here. We look forward to your sharing.
Thank you very much. Greetings, everyone. The title of my presentation is on the slide, and I will start off. Next slide, please. So Nigeria is off track and on achieving its goal of vaccinating about 70% of the eligible adult population with COVID-19 vaccines. With the vaccines now in ample supply and national coverage rate is still less than 20%. We then know that vaccine delivery and demand challenges are the main bottlenecks to achieving higher vaccination rates in the country. Prior studies, including studies by us, have found that vaccine hesitancy is a major problem, as has been said earlier on. And this is fueled by conspiracy theories and concerns about vaccine safety and effectiveness. Although the government of Nigeria is really doing well and in tackling vaccine hesitancy with multiple communication strategies, these efforts have largely been developed and driven from the top, and they've had modest impact on the desired behavior change at the community level. So we are now 2 years into the pandemic. Everybody has been exposed to misinformation about the vaccine, and people now have entrenched views about vaccines. And these views may differ from community to community. So we therefore need a good understanding of the social behavioral drivers of vaccine uptake, coupled with hyper-local approaches that respond to these concerns and needs. So our project aims to evaluate the use of trusted messengers to deliver and co-design and co-deliver messages to their communities to improve COVID vaccine acceptance. The objectives are to, next slide, please. So the objectives are to assess social behavioral drivers of COVID vaccine uptake, to co-design and co-disseminate these messages, to demonstrate the effectiveness of this approach. It's a 12-month implementation science project funded by the Sabin Vaccine Institute, and it's being implemented in Gwagwalada, an area council in the Federal Capital Territory of Nigeria, which has a large number of rural communities. So here are the interventions we've put in place. We've conducted a baseline qualitative interview, a set of interviews with 74 individuals, including healthcare workers, adults, community leaders, program managers at all levels. We've also done an online survey of healthcare workers and a representative household survey with about 15,000 adults. A theory of change is grounded on the WHO Behavioral and Social Determinants Framework, the ESD framework, which looks at what people think and feel about vaccines, what social processes or individual motivations influence vaccine behaviors, and what practical factors affect people's ability to seek and receive a vaccination. So using our baseline data, we have systematically explored these domains to really understand what's happening in the community. And then it's now guided the development of tailored messages and strategies with the community members. So our survey will also give us baseline COVID vaccination rates that we will now use to compare at the end of the study. So from our survey findings, we identified people who are hesitant about taking vaccines. Discussions with the community leaders, we also identified people they consider as trusted messengers. And then with these, we have then conducted human-centered design workshops with these trusted messengers, with health workers, and then with the hesitant adults to then co-create and design messages that address the specific community concerns. So over the next 4 months, we're going to support these trusted messengers to disseminate these messages in different community forums, such as chiefs meetings, women's groups, and youth engagements. And during this time, we will also monitor the dissemination of the messages and address emerging concerns from the communities through these trusted messengers. Our team will, in addition, send SMS messages as reminders and nudges to community members to tell them where and when to get the COVID vaccination. And then in November, we will commence the end-line qualitative interviews and household surveys to assess the changes in social behavioral drivers, change in vaccine coverage, as well as conversion rates among the subset of hesitant individuals that we identified at baseline who agreed to be followed up longitudinally to see how their attitudes and intentions about the COVID vaccine changed during the study. So we are now at the stage of launching the messaging approach that we co-developed with the community. Next slide. So I want to just share you a few findings from the baseline assessments. First of all, COVID vaccination rate among the healthcare workers was relatively high at 83%. But these healthcare workers were a convenience sample that were sampled through snowballing in identified health facilities. But there were some healthcare workers that were not vaccinated. So among these non-vaccinated samples, 34% were hesitant or uncertain about getting the vaccine. Then among the adults, vaccination rate was 2 times lower, so it was 44%. And then for the unvaccinated adults, hesitancy rate was actually similar to the hesitancy rate among the unvaccinated healthcare workers, which was 34%. But notably, willingness to get vaccinated among these adults who were not vaccinated was 66%. Next slide. So looking deeper at the characteristics associated with low vaccination rates, we see that among healthcare workers, Christians and secondary healthcare workers were less likely to be vaccinated than Muslim and primary healthcare workers. For adults, Christians were also less likely to be vaccinated than Muslims. Furthermore, women, younger adults, non-educated people, and those employed in the private sector were less likely to be vaccinated than men, older adults, postgraduate degree holders, and government workers, respectively. The main reason for non-vaccination among healthcare workers was concern about vaccine safety. For the unvaccinated adults, the main reason was low risk perception. So 72% were either not concerned about COVID or had very slight concern about COVID. Now, also important reasons for the non-vaccinated adults were practical things like not knowing where to get vaccinated. About half of them said this. Not being offered the vaccine yet, and not knowing that the vaccines were available. So some of them were also concerned about vaccine safety, side effects, and effectiveness. And then about 10% were distrustful of the government. Next slide. In this slide, we see just the consistency of the survey findings with what we found in the qualitative results. And the dominant themes were related to concerns about adverse effects, vaccine efficacy, distrust in government, and long wait times, vaccine unavailability, and also gender norms were prominent. Next slide. So we're halfway through our study. What have we learned? We've learned that a third of unvaccinated Nigerians in this sample are still hesitant about COVID vaccine. It means that a lot of people still believe in the misinformation about the vaccines, despite national communication efforts that have been put in place. There's a good proportion of these hesitant people who are still unsure. And so there's room to change the hearts and minds of people into getting vaccinated. And if we use more interactive and interpersonal approaches that allow people to voice their concern, ask questions, discuss, explore, so that they themselves can come to an understanding that allays their fears and moves them to get vaccinated. We also see that there's a huge unmet need for vaccination. Recall that among the unvaccinated, 66 were willing to be vaccinated. So practical issues like not knowing where to get vaccinated or vaccination services not being available still constitute a major obstacle. So messaging and behavior change communication alone will not yield the results we want. We need to pair behavior change communications with vaccine delivery efforts to ensure that a change of heart converts into a shot in the arm. Now, in terms of our study approach itself, we found that recruiting hesitant health workers was challenging because they were afraid of stigmatization and losing their jobs. We also found that involving trusted community members and vaccine hesitant eligible adults is feasible in developing a repository of messages that are evidence-based and address community needs. We found that leveraging community structures work, and then this can help us, drive efficiency and sustainability. And then finally, bottom-up approaches do lend themselves to engender community-grown and owned efforts. So involving managers in, vaccine managers in the human-centered design process that help to build their skills and how to use this approach. And these skills can be used in other ways that they work in. So I'd like to, last slide, I would like to conclude by acknowledging my colleague, Ms. Chisom Obijefu, who led the study with the capable team at Women Advocates for Vaccine Access and Direct Consulting and Logistics in Nigeria. I also want to thank the Sabin Vaccine Institute for funding this study. Thank you for listening and thank the organizers for the opportunity. Thank you.
Elizabeth, thank you so much. I hope that you'll have a chance to skim through the chat comments because the chat box is on fire. People have loved your presentation. Spot on. Really, and I personally can say that I really appreciate your characterization, your design, taking a bottom-up approach, as you say, and really deeply involving the community themselves in this process, from identifying the trusted messengers to taking a human-centered approach. And very importantly, I underscore your emphasis on formative research to understand the specific contextual issues in the areas where you were working, and then dialoguing with the community around those issues. I would note also your use of technology, mobile phones with the SMS messages to have a consistent reach to people also. So yeah, have a look through the chat. It's wonderful. People have greatly appreciated what you're doing there. Okay, we have one more presentation before we move on to the discussion, folks. We'll go to Faisal now to speak about a very different approach. This is very different, everybody, and I look forward to the participants' thoughts on the approach in Pakistan that Faisal is going to share just now. Faisal, welcome to you. Please share what you've done in Pakistan with us.
Thank you, Dan. Yes, this sort of case is slightly a case of the shock of the old. It's somewhat different. So today I will be looking at how vaccine-related restrictions improved vaccination compliance in Pakistan. In other words, I will be briefly speaking about how Pakistan's government used restrictions to influence health-related behaviors and generate demand. UNICEF's role in this was that we were the sort of primary providers of technical assistance in RCC. So we played a key role in sort of supporting them and sharing evidence with them and helping them use that evidence to design interventions. Next slide, please. So when vaccines became universally available in Pakistan, the behavioral predictors for vaccine uptake were poor. And these have largely remained unchanged. Based on UNICEF data, we know that Pakistan has characteristically experienced persistent vaccine hesitancy at 40%, very low risk perception at 28%. I'm calculating for severity and likelihood of infection here. Extremely low COVID-19 prevention at only 3.35%. This is based on 2 national observation surveys that we used to assess hand hygiene, social distancing, and face mask use. And also extremely low levels of low knowledge of variants at only 5%, which of course raises the question, how far can you use the appearance of variants as a motivator for the uptake of vaccines or even preventative measures, which is an important question. So the problem we faced in Pakistan was, how do we achieve vaccination compliance in a population that is significantly vaccine hesitant? A solution to this question became even more urgent as Pakistan faced, 1, a major crisis, which was the emergence of viral variants, and 2, a key constraint, limited resources for standard social and behavior change strategies to increase uptake, including community engagement, tailored communication to hesitant populations from trusted sources, and flexible access to vaccination for at-risk and vulnerable groups. Given this situation, the government used the strategy of vaccine-related restrictions to influence health-related behaviors and generate demand for vaccines. This meant that the government essentially outweighed certain rights to achieve public health benefit, but this public health benefit was well defined at that stage. Next slide, please. So the solution was specifically by late August 2021, and this was sort of reported globally as well. The government of Pakistan introduced vaccination as a condition to access public goods, such as education and public offices, livelihood, employment or employment salary and benefits, communications, for example, use of access to cell phones, transportation, air travel, and association, congregational prayer, religious events, wedding ceremonies, funerals, etc. The key features of these restrictions were that these were prioritized but granulated. By that I mean that these first targeted at-risk and vulnerable groups such as healthcare workers, and then opened up to all other subgroups across gender, age, location, and socioeconomic classifications. And in addition to that, these restrictions were proximate, which is important in that these were not far away in time, but immediate in terms of their cost. We know from behavioral evidence in Pakistan that immediate restrictions that disrupt everyday life are far more effective than restrictions that appear at a certain time, at a certain later time, or that impact longer term plans that people have in their lives. So something that is far more immediate and perhaps can even affect something very small is far more effective in many ways. And that's counterintuitive, but quite important. Lastly, these restrictions came with a high likelihood of detection, in that the government used centralized mechanisms, federal or led by the military as well, to detect non-compliance. So, for example, the national database, which used the status of vaccination and used that to, for example, block SIM cards for people, or block entry to certain places, or block salaries for government officials and servants, so on and so forth. So it was quite centralized and used sort of a national database and a national delivery mechanism in order to implement its penalties. The effectiveness of these restrictions was measured using longitudinal gap surveys, as well as social media listening and feedback captured from the National Helpline. These were done by UNICEF under the leadership of Jonathan, who is our chief of section. This evidence was corroborated by incoming data on vaccine uptake as well. Next slide, please. So the outcomes were, with the assistance from UNICEF country office, the government achieved high vaccine compliance at 82% within the test population, despite vaccine hesitancy remaining high at 40%. 61% of vaccine hesitant Pakistanis got vaccinated, and this amounts to a vaccine uptake dividend of nearly 21% within the overall population of the country. The key reason for vaccination, according to our measurements, was also not solely health, but overcoming vaccine-related restrictions. So the health was already a very weak motivator, but we were successful in introducing restrictions as a key motivator, which apparently worked. So the restrictions acted as a key inflection point. Without controlling for vaccine ineligible populations, for example, children at that time, we saw that in the first 6 months, compared to the first 6 months when there were very or limited restrictions, no or limited restrictions, and the next 6 months when there were restrictions, the vaccination rate has on average doubled during that time, and that was and that's quite significant. From the evidence generated by UNICEF, we have identified a number of enablers, and these were the lessons that we learned from the work actively while we were doing our sort of monitoring of these interventions. The key enablers in relation to these restrictions were their comprehensive scope, which had a whole of society effect, which is very important. Their delivery was effective due to a nationally centralized delivery mechanism. There was also clear public communication, which used high exposure, high frequency channels. There were, of course, key challenges too. Not all subgroups were uniformly affected by government restrictions. That we had outliers such as young people, particularly females, and the province of Balochistan. And then, of course, moreover, there are significant questions about long-term efficacy of restrictions as well, given ethical concerns, community resistance to restrictions, as public health benefits become lower stake or vague over time. And of course, if vaccine hesitancy remains unaddressed with other supporting behavioral interventions. So I conclude by saying that we need to develop, I believe, and this is something we're working on, country-specific algorithms that help interventions determine whether, which, and when restrictions should be used to achieve vaccination compliance. These algorithms should be able to offer pathways for vaccine uptake, starting from vaccine approval through to successes and failures of public communication and the relevant ethical and value judgments we make to the considerations of alternatives. One key alternative, of course, as we discussed here today, were our vaccine-related restrictions. And thank you again. I look forward to the discussion today on these. Thank you.
Faisal, thank you so much. Again, this approach in Pakistan is very different from the other approaches and interventions that we've been hearing about. Fascinating to hear about the level of success that you're able to report based on this approach. But I do note what you opened with saying about the decision that the government of Pakistan taking in outweighing the concept of rights and civil liberties, if you will, for the prioritization of the public health benefit. I think there are a lot of questions around that. You'll see in the chat also a lot of appreciation for what you've shared. And so we thank you for that. Okay, and I'd like to thank all of the presenters for really sticking to time in your presentations. Well done to all of you. That leaves us with quite ample time now to take on a good number of questions from the participants. I have colleagues in the background who have been reviewing them and prioritizing some for me to share with you. I'd like to invite all of the panelists to put your videos on at this point, and we will try to direct questions to each one of you somewhat randomly, perhaps. Martin, I noted in your presentation that there seemed to be a higher uptake in the vaccination amongst men rather than women. I wonder if you have any insight on that particular point. And I want to link some participant questions to that point. Some of the participants are asking about special considerations for pregnant and lactating women. I invite you to speak to that. And if others would like to speak to the question about pregnant and lactating women, perhaps you could put your hands up and I'll come to you as well. So let's start with you, Martin.
Thanks. And thanks for these wonderful questions and comments along the way and these amazing presentations. So on this issue, we see this, I think, also for other vaccines, that women tend to have a lower acceptance rate. And I think that one of the core reasons is exactly what you mentioned, right? So it is greater concern over side effects for, particularly for lactating and pregnant women. And so we link it to the questions that were raised related to hesitancy more generally and the ways that what we've learned about hesitancy in these places more generally. What I find was interesting and that motivated this study is that many of the reasons that people mention on why they would take a vaccine or not, if you just did a bar chart on the percentages of reasons listed, they very much match what we hear here. People are concerned about side effects. People are concerned for themselves, are concerned for others. People take a vaccine because they would like to protect themselves and others. Many of the same reasons that we hear in many other places. So I think one just good point to note there, it isn't that, at least in our research, it isn't that people where uptake is low have wildly different reasons as far as we were able to see. And I think that helps us also think about what we need to do to reduce further hesitancy, right? There is, particularly in rural areas, less opportunity to get to trusted sources of information, right? It can take away reasons on why you may be more hesitant or questions you have related to vaccine efficacy or vaccine safety. So going out there has taught us that we can increase acceptance, but also that we can, that well-trained teams can take away many of these concerns. People just want time, they want to be taken serious. And that actually means going to their homes where they work and where they live. And some people may not be willing to come to community meetings and speak about their concerns in a public forum. So we felt that particularly the door-to-door mobilization has helped some people address concerns in private with a ministry social mobilizer. And that we need to invest a lot in the quality and the training on the way that is done, but that can take away a lot of people's concerns and move intent further to action.
Well, I love what you've said here, Martin, about people wanting to be taken seriously. That is the heart of it, isn't it? Yeah. We cannot make top-down assumptions. I think this is at the heart of Chizoba's presentation in Nigeria as exactly well. Right. Let me ask the panel, would anybody like to speak to the question of specific considerations for pregnant and lactating women? Chizoba, over to you. I saw your hand fluctuate there.
Yeah, yes. So I think one of the reasons why there is hesitation about pregnant women getting vaccinated is the rumors and misinformation that emerged after the vaccines were developed. And there was also a lag between making WHO and other regulatory organizations making strong recommendations or making recommendations for use of the vaccines with in pregnant women versus use of the vaccines in the rest of the population. So that the combination of the rumors about the vaccines affecting fertility and there not being a strong recommendation in the beginning, when the vaccines were being rolled out, sort of created this lacuna. And so the people still have a lot of questions. Now, when you add that to historically, historically, pregnant women have not really been involved in vaccine trials. So by the time new vaccines come out, there is no data to inform recommendations for pregnant women. And so that leads to this vicious cycle of pregnant women not having access to vaccine because there is no data, and then them being exposed to the risk of the pathogen that the vaccine is preventing. So, but in many countries now, WHO has strong recommendations that are par with the general public, and we just need to educate the health workers more, because sometimes the health workers actually were the ones who did not know that it was okay to vaccinate pregnant women. In fact, some pregnant women will come and they will turn them away. So we need to educate the health workers so that they know that it's okay, and then also educate the public and let them know that after almost 1.5 years of the COVID vaccine being rolled out, we don't see any adverse effect or high adverse effect among pregnant women and their unborn children.
Thank you, Chizoba. Since I've got you on the mic, I'm going to ask you a follow-up question. One of the participants noted that in Nigeria, one of the major concerns is that the vaccines are not available and accessible to people at the low socioeconomic level, as well as generally people dwelling in rural areas. This participant didn't feel that your presentation really spoke to these effects. What do you think?
Yeah, I responded, and I agree with the participants that in our study, we found that folks in the rural area and then people in the low socioeconomic class had lower vaccination rates. And of course, that has to do with the delivery. There's a lot of delivery challenges to rolling out the COVID vaccine. And I think the government has just started with the low-hanging fruits, which is delivering to the urban areas and high-volume facilities. People in these rural areas, their facilities are usually low volume facilities. So it's going to take concerted efforts, much like the ones that Martin described, and the efforts with a broad range of stakeholders, including civil society organizations, where as you go to the communities, you're educating them, allaying their fears, you're also coming with the vaccination services. So I really like that model of the mobile vaccination teams. And then these are some of the strategies that I believe can overcome the access barriers that rural folks have in receiving the COVID vaccination. Thank you.
Thank you, Chizoba. That's very clear. Chima, over to you. Tanzania. Many questions coming from the participants. Let me give you a flavor of the questions that are coming in regards to the rolling up sleeves approach that you've taken. Was there data collected on the barriers to vaccination in conjunction with your approach? Have you segregated data on which groups got vaccinated first in the event approach? Who got vaccinated at these events? Was it really vulnerable populations there? Did you address different kinds of barriers from different high-risk groups in this approach, or was it more just a kind of blanket approach? Let's start there.
Okay, thank you so much. Actually, I also have picked almost about 9 questions, and some colleagues have helped to pick more. So it shows how interesting the topic is. But let me start with yours, because you are the first to throw the question on how the event-based vaccination has been taken to wider impact beyond the events. I would like to say that one of the things we've done was to pilot this concept. We started with the football, and then we did piloted it also at a musical event called the Serengeti Musical Event. And also we, during the last launch, the launch of the Global Vax on the 2nd of this month, we also piloted this at the event of the launch of the Global Vax, where about 436 persons were vaccinated by just one team. And at the Serengeti Musical Event, over 200 persons were vaccinated, and then across several football fields. Now, what were we trying to do? What we were trying to do was, one, to even convince ourselves that this works, and that if people are not going to the health facilities, that if you take vaccines to where they are, whether during events or at some other locations, that it works. So whether this has been taken to wider impact, I would say no. However, the country is currently planning an accelerated COVID-19 vaccination campaign. And in the micro planning that is being developed, event-based already has a column for it to be captured during the nationwide vaccination campaign. Now, when this is done, then we'll be able to say on a larger scale, yes, that this works in a larger scale, but in different locations across about 8 regions, and then across about 4 events, 4 different types of events where this has been piloted, we have evidence that people are willing and actually got vaccinated. There is none of the events where we've taken vaccination teams to, that the team did not run out of the number of vaccine doses that they actually went to such events. Then secondly, there was a question on whether I think the event-based vaccination is actually based on agreement or positive acceptance from the community or that. So now, looking at this, we don't just jump into event because we hear that an event is taking place. Usually, it's a process which starts with an advocacy meeting or sensitization with either the organizers or the community where such event is taking place. Now, this is to ensure acceptance and also to make sure that the participants and the such events. So we always ensure that the leadership or the organizers or the community where it's accepted that the team will come. As a matter of communities, one of the districts in Tanzania, with the regional commissioner for a meeting with the stakeholders, including community leaders and religious leaders, because we're planning to launch, in addition to other strategies, event-based vaccination on the 28th of this month in Manyara region, which actually is one of the, actually is the worst performing region in Tanzania. So our events are usually preceded by a lot of preparations and sensitizations, negotiations, advocacy with the communities even before we go. Thirdly, if someone found it difficult to relate evidence that 71% of Tanzanians are willing to get vaccinated, and yet only 7.7% are vaccinated yet. Well, your impression is not far-fetched, is not misplaced. I can agree with you. But we also do know from experience that someone might be very knowledgeable, yet behaviorally irresponsive. Knowing it is different from doing it. And that's why we have in communication theories that we call the knowledge action gap theories. Someone might know something and will still not take the necessary action to do what he even believes is meant to protect him. We all do know, and it's written in most countries on a cigarette packet, that smokers are liable to die young. But you still see someone who has picked this cigarette pack, remove a stick, light it, and be smoking, even while reading that smokers are liable to die young. So someone might know something and still not take the necessary action to protect himself from such. So we have a lot of research evidence that are not even conducted by WHO. The latest one was done by UNICEF, which was presented to us last week. And that shows that about 61% are still willing to get vaccinated. And some other research evidence have also proved that independently, the last 2 quarters, WHO conducted engaged independent researchers, and they also found out that more than 2/3 of Tanzanians are still willing to get vaccinated. But taking the action is a different thing altogether.
That's
Barriers
good news.
to uptake.
That's good news, Chima. I'm going to interject there. We want to move a bit to some other questions, but you've highlighted very important points about the approach in terms of the wider advocacy and communications promotion that took place in the communities prior to the event's approach. And I think that's fundamental to what you've been doing there. We'll come back with a couple more questions there. I want to go to Faisal. Faisal, there are inevitable questions from the participants about the approach in Pakistan. They would have been the same questions I would have asked also. Let me just paraphrase a little bit. How do you explain the aspects of what this participant refers to as human rights violations in regards to the approach taken in Pakistan? Subsequently, were there any issues of human rights objections or legal rights issues raised in the communities or by any groups? And in a different vein, but a very important question around the relationship between improving health-seeking behaviors in the long run and this kind of compulsory approach versus a more social behavior change type tact or approach to it. So you've 2 areas of questions. You know, what has the human rights discussion been like in Pakistan around this? And what has the discussion been around improving health-seeking behaviors versus taking the compulsory actions?
Thank you. I'll take the second question first because it's slightly less complicated. So I should add that the government, what they did was they lapsed the restrictions after a certain point. So once someone complied to the restrictions at one point, these sort of didn't apply again. What that did was, and we have evidence on this, longitudinal evidence on this, that people who were then essentially sort of instigated to participate in the health system actually developed a high level of sort of trust and reliance on the health system as well. So, and then they continued to use the health system, which they were not able to before. So the restrictions somehow acted as a trigger to enter people into the health system. And we're talking about a population in the country, which is not generally which does not have significant levels of health-seeking behaviors in the first place. So I think the restrictions work that way, and they lapsed as well. So Pakistan right now is under no regime of restrictions as such that is actively pursuing people. So that's, I think, around the health-seeking behaviors, I think that's one thing. But of course, there are challenges. And that is what I sort of try to highlight as well at the end, that we do need to address vaccine hesitancy. We do need to improve health-seeking behaviors. There's a certain kind of a political economy around health in Pakistan, which needs to be addressed. And I think which was addressed to an extent by the health vaccination centers and the investment that the government made around those. And that sort of built public trust and some fascination and participation with the system as well. And people participated in it in large numbers. So I think that's the sort of approximate answer to the second question. On the first question, there were groups that did, of course, journalists, international journalists as well, national health right, human rights groups. They did raise issues, but these were sort of just this was more reportage or sort of just reporting it or echoing it rather than creating some kind of legal action or some kind of sort of debate around it that was actively obstructing these restrictions. So it didn't really amount to a significant pressure. What I should say is that vaccination, we know generally, offers benefits. And we do also know that one can only be compelled to do something if there is a proportional response to the risk as well of harm that it poses to others or to yourself. So I think the case I made for the algorithm is exactly this, that we should be able to decide more carefully when can we use them. And one of the factors that we should be using to make that assessment is the sort of harm principle that we're using and sort of the ethical justification that we need to make for these kinds of interventions. The two ethical features of that we were looking at, I think the government was looking at, was infection, even from asymptomatic people, and also the sort of overwhelming pressure that the health system would have faced, which was quite visible in urban centers in the country. So in a way, I think within that context, the population did comply. And I should add, and this is sort of a more social theory observation, there is a sort of a tradition of state parentalism in Pakistan, which works quite effectively. And actually people are far more familiar and comfortable with that. That is something that behavioral researchers should look into and try to modify the relationship between the public and the state. And I think in a way the vaccination centers and the have modified it somewhat. The political economy shifted very rapidly. People were quite they were happy with the sort of investment that the government had made and trusted it eventually quite significantly. So I think that would be my response. So I would say things are still complicated. Of course, the question is whether you can maintain these for a very long time, and it's impossible to maintain restrictions over a very long time, or even for a second or third or fourth round of vaccination doses. It seems quite impossible. Thank you.
One more question there. Another participant asked this, and I think it's an interesting human rights related question. Were the restrictions, in your observation, were the restrictions applied equitably across all populations, or was there any sense of inequitable burden of those restrictions on more vulnerable groups or any specific groups, or was it really flat across the population?
Something very strange that we observed, it was the other way around. So people who were sort of characteristically in more inequitable settings actually evaded restrictions because of the centralized system that the government was using for example, mobile phone access. So a significant part of the population, including females or a significant part of the population in Balochistan are not using mobile phones or cell phones. So they were never subject to restrictions at all, and so we see low vaccine compliance there. So inequity, in a way, was in a way sort of undermined the effectiveness of these restrictions. But of course, particularly when we look at livelihood shocks that these restrictions produced, that is quite concerning, particularly for government officials and government servants. And so we did surveys of teachers, of health workers, and there was significant reports of harm to them. I think particularly for healthcare workers and public servants who were working at a sort of a lower hierarchy, I think, at a lower level of the hierarchy. So I think that is true. But inequity in a way sort of offered an advantage, I think, in evading restrictions, oddly enough, given the system that was being used in the country to implement these restrictions. Thank you.
This is Faisal, brilliant sharing. Thank you so much. And I'd like to thank all of the panelists. I'm afraid I'm informed we're running out of time now, but your contributions have been really reinforcing of a lot of strong ideas for our ongoing advocacy moving forward, our understanding of the dimensions of demand creation in conjunction with access issues, and very innovative approaches here that I would say probably all have merit and would be good to all bring together in a synchronized approach. Let me just underscore a few thoughts that stand out to me from the presentations. One, the importance of formative research on the front end of our community engagement and risk communication development to really appreciate the nuances of context. Faisal was just sharing, that in Pakistan, there is a sense of collective responsibility. That's a very important understanding to inform interventions in Pakistan. So formative research, very important. Then moving on to human-centered design, as Chizoba was speaking to, also intervention designs that actually resonate directly with the population and specific populations so that they're a part of it and they can speak into the interventions that are being offered because they're for them. Also using resources from the communities themselves because they are trusted resources. Many of our panelists spoke to that, including Martin's example of the social mobilizers and the using trusted champions in Nigeria. I think we should highlight that many of these recommendations are in fact established at a principle level in the WHO behavioral and social drivers framework. So we can turn to that framework as one of our starting points also to guide these same kinds of recommendations in a systematic way, and that's an invaluable resource. I wish that we had had time to speak about the issue of vaccine hesitant healthcare workers specifically, because that is a very interesting barrier at the level of frontline health facilities, and I think requires a special attention and investment. I liked what Martin was sharing about the importance of aligning the demand interventions with good access, bringing the vaccines to an accessible level for people. We cannot discount the costs, the time, the labor, all of the logistical barriers that vulnerable populations face in regards accessing the vaccines and aligning that access to the demand side interventions that we're making. And finally, the final comment I will make is that underlying much of our discussion is the question of long-term health literacy development for our populations and being able to create a culture of interest in health outcomes, willingness to engage health interventions because people can appreciate the importance of them, not only in the crisis situation, but in the non-crisis points, such as where people perceive we may be now. So once again, thank all of you very, very much. Thank you to the participants also for your very astute questions, and we look forward to the next session oncoming. Thank you.
Hi, colleagues. We are going to take 5 minutes break, Sheetal. So I think that's why the music is there. Sorry about that.
Good afternoon, everyone. Am I good to go, Adifa?
Yes, Sheetal, yeah, please go ahead, yeah.
Thanks so much. A warm hello to everyone from Geneva. Currently at the Gavi board meetings, and happy that a lot of the issues we will be talking about today and tomorrow are also being discussed as list level with across the Global Alliance partners and further. My name is Dr. Sheetal Sharma, Senior Immunization Advisor in Core Group, and have also been working closely with the Gavi CSO constituency over the past 3 years. Today, I really want to emphasize in this session, how do we deliver health service interventions of quality that meet people on their terms, and especially getting to that last mile. As we know, there have been a growth in interest on how to work with defaulters, under immunized, under vaccinated, what some folk are calling zero dose, on how to think through outbreaks, also to think through what capacity are we able to evolve with emergent outbreaks. As you've seen in the news, there is a new disease of concern, and although with polio, when we're talking about getting to the last mile, how can we get there, and what do the new vaccine introductions and the new policies help? One of the biggest statements that is coming out this month is, how do you get from policy to practice, and you bridge that gap between the global level and the community level. Today, the panel will focus on service quality and the impact of quality services that have on the uptake of COVID-19 vaccines. Research shows that a focus on service quality, addressing both the easy access to vaccines as well as the demand, can increase confidence and trust in a vaccine and in a health system, resulting in greater acceptance of this vaccine. This is no more truer than in hard-to-reach vulnerable populations, some often in fragile states and humanitarian settings. A key driver that influences the caregiver's decision around making vaccine acceptance is, what are the assets, what is the PHC system like, and how can you improve the health worker and client or caregiver interaction. The interaction has a critical impact on the caregiver and, of course, on their own trust, and in the subsequent acceptance of the vaccine for the children and themselves. This interaction is key, and it's a huge component of service quality. Humans use the health system, so how can we make it a more emotionally intelligent and more human aspect when we are talking about these issues? How can we support, how can we strengthen the quality of service for vaccination? And how can we bring those services closer to people? I can see a number of my colleagues, some of you I know, a big hello, and you are those who have often advocated to bringing those services to the people because of all the barriers that are implied at the community level, whether it be from gender to distance, to resources within the community to get there. I'm hoping this session will present examples, and I'm very excited about the speakers that will be there, of how the services are brought not only closer to the community and the quality of the caregiver and client provider interaction to strengthen these efforts together to improve COVID-19 vaccine uptake to keep our populations healthy. A warm welcome to the 5 presenters. I turn first over to Charlotte and request an introduction as you put up your deck, and welcome. Thank you.
Thank you so much, Dr. Sheetal. Just a quick introduction. I am Cynthia Najjar. I am the Emergency Health Officer in IFRC MENA, and today I will be presenting on behalf of the Syrian Arab Red Crescent, and I will be showcasing through the presentation the activities undertaken under generating COVID-19 vaccine demand and encouraging vaccine uptake. Slide, please. Thank you. So just to give a brief introduction on the context, Syria is one of the countries in the MENA region that has the lowest COVID-19 vaccination rate. Up until very recently, only 15% of the whole population has been vaccinated. And out of these 15%, only 9.6 would receive their whole vaccination protocol. Syria having been troubled with protracted crisis for the last 10 years. It has currently around 6.7 million IDPs, who constitute around 37% of the total Syrian population. So SARC conducted recently a CAP survey to identify the reasons resulting in a very low vaccine uptake. In total, 384 surveys were filled across the 7 governorates in Syria. So as a result of this CAP, the analysis showed that the main reasons behind the low vaccine uptake were mainly linked to vaccine hesitancy within the general population as a result of a lot of rumors being circulated in the communities regarding the vaccines, doubts regarding the vaccine efficacy, and the fear of its side effects. Also, there was a lack of trust regarding the sources of the vaccine. Another problem was that the Ministry of Health was incapable of reaching with the vaccines some of the very hard to reach areas due to very limited resources. Also, there was a lack of knowledge from the side of the people on how to register for the vaccine and to receive it in the places where it was available. Slide, please. So following the results of the CAP survey, actions were taken to combat rumors and provide the most vulnerable people with access to the vaccine. Just to give a side note, SARC is the largest community-based provider for humanitarian aid in Syria, and it has a very large web of community volunteers and community health promoters. So these volunteers, in the period of around 3 to 4 months, were able to conduct around 24,000 awareness sessions in targeted communities across Syria. As a result, also a total of 370,000 people were reached through household and door-to-door visits. Around 300,000 people were assisted with the COVID vaccination registration process and were referred to specific vaccination centers or mobile vaccination teams. The Ministry of Health had around 300 mobile vaccination teams that were specifically going to hard to reach areas. So coordination was made between the people in these communities and the mobile vaccination teams in order to reach the most vulnerable and hard to access communities, including never been accessed before IDP and refugee camps. Also in areas where even the Ministry of Health vaccination teams were not able to access, the volunteers and health promoters were transporting the people who were wishing to receive the COVID vaccine to the nearest accessible vaccination point. The number of people who received the vaccine after participating in these activities and qualitative data and stories from the field were used to measure the impact of these actions. Slide, please. So following these actions, the impact that was seen, some of the impact that were seen is that around 26% of the people who received sensitization messages and attended these awareness activities received the COVID vaccine in a very short time frame, out of which 20% were people who were from the most vulnerable groups, including people with disabilities, IDPs, people with non-communicable diseases. Another story is that in one of the communities with a high number of IDPs and returnees in the governorate of Aleppo, the vaccination rate reached 95% among the people who were aged 18 plus following the community interventions. Community leaders and gatekeepers from many communities became advocates for the COVID vaccine. In one of the IDP camps, a gatekeeper who was before convincing people not to get the vaccine because of his own fears and doubts, was able to convince 40 people to get the COVID-19 vaccine and thus encourage uptake in his own community. Also, the SARC health promoters were able to reach one of the Bedouin camps that has never been accessed before by any national NGO, by any NGO, a national NGO or international NGO, with information regarding the COVID-19 vaccine, and as well information on routine immunization. The teams were able to earn the trust of these communities, and a lot of people agreed to receive the COVID vaccine, and also the Ministry of Health reached these communities after the interventions with routine immunization vaccines as well. So what are the key learnings from these interventions? Some of the key learnings that we got and that we are eager to use in the future are that it was very important to link and to create this link between the Ministry of Health mobile vaccination teams to the communities that were hardest to reach since we had the access. Gaining the trust of the community gatekeepers and the camp leaders played a huge and crucial role in advocating for the COVID vaccine uptake. Close coordination with the Ministry of Health field offices as well was very important. Tailoring sensitization messages to the specific context according to each community targeted, while taking into consideration the different customs and cultural norms that were preventing vaccine demand, and targeting these specific issues was very crucial. Also, coupling sensitization activities with on-the-spot vaccination for community members who wish to get vaccinated yielded a lot of very good results. Thank you very much. And I'll be glad to get the questions after on. Thank you.
Thank you so much, Cynthia. Really inspirational to hear from you today. I wonder if we can move on to, as we will be taking the Q&A at the end of the presentations, I wonder if we can move on to the next speaker, Carla. Over to you. Thank you. Merci, Carla.
Okay. Merci beaucoup, Chita. Je vais présenter en français. Et j'aimerais aussi remercier les organisateurs de cet événement, en fait, pour nous avoir accordé cette opportunité de relater, en fait, notre expérience dans la mise en œuvre.
Extremely important event. So we are talking about experience of a high volume vaccination site, Vaccinodrome, so as to in increasing access to COVID-19 vaccination in Kinshasa. Our country, Democratic Republic of Congo, experienced in 2021 a specific situation où la situation où on a installé ce genre, a specific situation where we got these specific vaccination centers. We have an organization which is present, has been present since 2015. So we have cooperated with the health ministry so as to improve this situation having to do with vaccination. It's an experience that this specific organization had in the Ivory Coast. So you have been able to manage the most complex situations. We have been able to manage and to be present in those areas. So apparently we have a problem with the translation. Just a few minutes so we can double check if it works. Apparently it works, everything fine and goes on smoothly, but Let's double check. This is the English channel, translation French into English.
Okay, Carla, please continue in French. We have translation now. So just log on to the interpretation language colleagues and get the interpretation into English.
Oui, merci Carla.
Ok, merci. Je vais peut-être pas reprendre dès le début.
Okay, I would like to start from the beginning.
Corbin, please change the slide. The next
slide, please. OK, thank you. Voilà, et donc, je disais justement que c'est en 2021 que Village Reach, dans son appui au ministère.
So we have been able, in the year 2020, 2021, we have been able to set up a vaccination site, high volume vaccination site. We call it Vaccinodrome, that is to say vaccination hub. The idea to streamline and help the access of the public to vaccination. There were cases, for instance, of misinformation, and we have been able to manage this type of communication as well there. So the objective was to vaccinate 1,000 people per day. In the first months, we set up this vaccination hub, despite the fact that we got to very good results, i.e. very good vaccination results vis-a-vis urban areas. Still, with respect to the data that we got day by day, we have not been able to complete and to achieve that specific 1,000 per day. So we needed to understand how to improve access by the population to these hubs. So what did we do? We also got support from community leaders so as to spread information, positive information, and to identify people so as to address them towards this vaccination hub. So first of all,
à répondre aux préoccupations du public.
First of all, we wanted to answer to the worries expressed by the public at large. We have been able to clarify all the different questions raised by people, and that allowed us to identify the right training module for those who had been identified to give answers to public at large. Then we have been able to address and get into contact with the public at large, but not just that, with vulnerable groups, which was our worry. So people within community had to be able to identify the person identified as information spreaders so as to be safe about the number of people present in our hub per day. So we got to 124 in terms of vaccination hubs, that is to say, vaccinodrome in French, so as to have a greater uptake of vaccination. This has been used as a reference, a base for vaccination teams, so as to move towards the different community. For instance, where bus stops were located or in other areas, more crowded areas, so as to be able to diffuse and spread the right information. How did we measure this? Thanks to the answers, the responses that we got, we have been able to get a measurement. Obviously, this was based on people going to our hubs, getting vaccinated, and providing the answer we were ready to listen to. Next slide. Outcome and key learnings. So we have been able to improve what's going on thanks to our hubs, or via mobile teams addressing different areas and going towards more rural areas. So this is called an advanced type of a strategy, which is more flexible. The different vaccination hub has been identified by the different communities, and we need to be flexible in terms of strategy, as I said, vis-a-vis our teams moving around. Then we have been able to improve our knowledge vis-a-vis the context.
So we teams had to adapt to this. Then we had also to think about to include not only the person vaccinated in the team, we also had to include the people who know the community and who can reach women, who can reach elderly people, and that is the information that is in the presentation I wanted to share with you, and I'm ready to answer to all of your questions in regards to the strategy. Thank you. Thank you very much, Carla, for this presentation, and thank you for sharing your information regarding this your vaccinodromes. Can I ask, please, the next speaker?
Charlotte, c'est pour vous.
Charlotte, it's for you.
And thanks for this wonderful opportunity that we have to share our experience of COVID-19 vaccination hackathon in Côte d'Ivoire. So I'm speaking today as a member of the Movement for Immunization Agenda 2030, a global community of immunization professionals who are seeking to reach the goal of IA 2030 and leave no one behind. So COVID-19 vaccination is very important to us. Next slide, please. So we all know, and it has been established that with the COVID-19 vaccination came an unprecedented surge in COVID-19 vaccine hesitancy, and even amongst the health workforce, and Côte d'Ivoire was not left out in this situation. That is why in the wake of a national immunization campaign that was planned in December 2021, together with the the National Institute of Public Hygiene and the National EPI team in Côte d'Ivoire, in association with the Geneva Learning Foundation and financial support from Gavi, alumni of the Geneva Learning Foundation's programs came together to try to look for ways to address this particular challenge, because there was a need for health workforce capabilities to be developed, not in the traditional way, but rapid speed was also needed to share lessons learned and especially on how to adapt national guidance to local contexts, not using the existing mechanisms that are primarily vertical. So the question to us was to see how to rapidly strengthen the National Institute of Health, EPI, and partner staff human resources of health capabilities based on what works ahead of the national COVID-19 vaccination campaign that had as goal to reach 6 million people in Côte d'Ivoire in December 2021. Slide, please. So in 7 days, using our fully digital hackathon package, country-based scholars, as we call alumni from our programs, they volunteered together with the National EPI to connect over 500 immunization health workers from the country Côte d'Ivoire and also other countries, and they were able to develop 165 context-specific action plans to accelerate COVID-19 vaccination. And it took a whole number of a series of processes that were fully online. The participants worked in small groups to problem solve context-specific COVID-19 vaccination challenges. And as I said earlier, most of them were related to vaccine hesitancy. Also, they developed action plans focused on local challenges or barriers to COVID-19 vaccination. And they took time to peer review the action plans that were developed by colleagues. And afterwards, based on the feedback received from the action plans that they developed, that feedback received from colleagues, they were able to revise and finalize these action plans and work towards implementing them during the campaign. And so we were able to measure the outcome of these activities via the actual vaccination uptake during the national campaign, and that were matched to the implementation of the hackathon plans. And also hackathon participants were able to share self-reported implementation, what they were doing on the field, as well as pictures. As you can see on the screen, that is a picture that was shared by a participant who was actually trying to implement his action plan during the campaign. Slide, please. So what do we learn from all of this? One thing, as I said earlier, there was it was owned and led by country health workers across all levels of the health system. And it was a hackathon for Ivory Coast, but they were able to garner, since it was purely digital, participants and peers from 20 other countries. And all of this was developed in 10 days. And at the end of it all, we had 165 peer-reviewed context-specific action plans. Most of these action plans, that is, were from Ivory Coast, as the 96 of the health districts in Ivory Coast were represented. Most of them, that is over 70%, were district and health facility staff, what we call the operational level. And if the action plans were implemented according to the reporting from participants, Ivory Coast participants in the hackathon, they were going to vaccinate an estimated 3.5 million people, that is over 50% of the target 6 million, with a funding gap requiring an additional $0.626 per vaccination. And 71% of participants implemented their action plans during the national vaccination campaign. And 82% were able to reported that they found a solution to better conduct the COVID-19 vaccination campaign through this whole process. And more than 70% said they were capable of using this methodology to solve their day-to-day problems. And also 82% wanted to be able to move forward with that. And so what did we learn from this process? That local solutions, when they are able to integrate them and use them in the campaign to anticipate, prevent, mitigate, and respond COVID-19 vaccine hesitancy. In my earlier slide, there's actually a quote from a health professional at a district level in Côte d'Ivoire that reported that she was afraid to receive the COVID-19 vaccine, even though she went out on a daily basis to engage and convince people to receive the vaccine, but she herself was not vaccinated because she was afraid based on the rumors and the misinformation on social media. So she had to observe over a period of 3 months other people receive the vaccine and be fine, for her to take up the courage herself to take the vaccine. And after she took it and was okay, she was able to convince others and other family members, and she gained more confidence when it came to talking to people about why it was important for them to take the COVID-19 vaccine. So it means that health workers' own confidence in COVID-19 vaccination and their own vaccination status is consistently reported as one of the most important factors in successfully engaging communities. Many a times, the health workers reported they had to present their own vaccination card or a picture of them receiving the vaccine or a video to get people to receive the vaccine. That is, health professionals are leaders by example. And so there was this countrywide digital peer learning network that connects different system levels to foster motivation to share what is learned. So it was digital, it wasn't face-to-face. And so it brought immunization health professionals from the health facility to sit in the same group with leaders at the national level, with other staff working at the national level, and together sharing their experiences on what they are doing to solve concrete challenges that they were facing. And all of this without having to leave their workplace, without having to go face to face, and on a voluntary basis. I'm going to end with this particular quote from a district health director in Côte d'Ivoire that said, during the hackathon, he was able to realize that he had to go beyond the traditional methods of engaging the community, that is going to the market, going to the church, places of worship, meeting with associations, to engaging with business leaders. That is those people that have others working with them, working for them, engaging them so that they could reach their staff and their workers. And he said he could not have learned about this without participating in the hackathon. Next slide. All right, so before I conclude, I just want to leave you with these two photographs that are showing all of the different strategies that were developed by the hackathon participants. The first one is a picture of what is called the OWL strategy. That is night vaccination, trying to reach people in the community at the time when they are most available. That was practiced in one of the health districts in Ivory Coast. And the next one is vaccination sites at the market. That is what has been reiterated throughout this event today, that is important to meet people with the vaccines where they are. Thank you very much for your kind attention. I'm looking forward to questions.
Thank you so much, Charlotte. Really interesting, and also a lot of the language you're using and this element of ownership. What does it really mean? Looking forward to Q&A on this shortly. I'd like to invite Anumega for your presentation, please. Bienvenue, Anumega. Thank you.
Thank you, Sheetal. Hi, good morning, everyone. I'm Anumega Bhatnagar, Risk Communications Lead with Momentum Routine Immunization Transformation Equity India project. And today I would be talking about, how deployment of mobile vans and integrated community engagement approaches have led to an increase in uptake of COVID-19 vaccination amongst the geographically hard to reach and elderly populations in the state of Assam in India. And just to give you an overview, the project M-Right works in 18 states across the country, from north to south and east to west, as I mentioned. with a single core objective of increasing demand, distribution, and uptake of COVID-19 vaccination amongst the most vulnerable and marginalized populations of the country. Next slide, please. So when the project began in 2021 last year, towards August, we were facing a situation where the country was almost at 60% of its vaccination with first dose, but a very slow uptake amongst its second dose and a large chunk to still go for the first dose. And specifically in areas, for example, in Assam that we're going to talk about right now, it's in the northern eastern part of the country, it's a northeast state. The terrain is very difficult. The terrain is geographically challenging. It's vast, it's spread out and scattered population. There are hamlets residing, at different points of the state. There are clusters of people staying together. There are rural clusters there. So it's a very large spread out state. And when the project started, we realized that there was low uptake of COVID-19 vaccines amongst these populations, owing to a few reasons that are marked here. For example, lack of confidence in vaccines. So lack of confidence was marked by multiple reasons. We heard feedback from the communities like, the trials have been hurried. Are the vaccines safe enough to take it? The vaccine probably offers incomplete immunity towards COVID-19 vaccine. Or, maybe the quality of vaccines is not up to that mark, or low quality vaccines are being sent to rural areas. So such kind of rumors came back. The population whom we were talking about, they had lack of access, poor access to vaccination sites. So almost 40% of elderly with disabilities did not have clear access to the vaccination sites. 20% of them could not travel to access the vaccination at the sites at that time. There was lack of sufficient resources and adequate infrastructure, specifically amongst the difficult to reach and scattered populations and those living in the hilly terrains of the state. And specifically in the northeastern state and in Assam, the second dose coverage was really low. The follow-up for the next dose was dipping down. And so hence, it was also the lowest amongst the vulnerable marginalized populations, such as the elderly and rural populations. So the challenge that we had was how can the project increase access and uptake of vaccines in geographically hard to reach and vulnerable populations, specifically amongst the older and the rural populations. Next slide, please. So as the most as a most workable solution that the project came up with close collaboration with government, the project deployed mobile vans which are combined with community engagement approaches and generated demand, mobilized the community and provided last mile delivery support. Influences and partnerships at the state level were leveraged. Local governments were engaged, community leaders were roped in to understand the causes of low vaccine uptake and identify potential solutions which were workable for the community as well. The solutions were designed cohesively. They were designed from the voices from the community so that it works. It has a sustainable component. It works for the community. Personnel were trained to communicate about risks and benefits of the vaccine, to address hesitancy and confidence in the language that worked in the zone. Local community-based organizations were onboarded to coordinate, mobilize, and raise awareness among geographically hard to reach communities on the mobile vaccination campaign through multiple media engagement and community health workers. While the media engagement talked about a lot of motivation and positive deviance towards vaccination, but this personalized approach to the community health workers made the connect with the community. The project collaborated with local NGOs to develop appropriate community awareness strategies such as door-to-door and interpersonal counseling. As a practical consideration, the entire push was on bringing the vaccination sites closer to the beneficiary. So the project deployed about 15 mobile vans to reach these hard-to-reach areas in the state, and for the elderly populations who were unable to make it to the vaccination sites. The project arranged transportation for them to the vaccination sites. They worked with district health authorities to identify the populations that lacked access. The project also provided facilitation in transportation and in registration also. The entire platform of CoWIN on which India has been working for COVID-19 vaccine registrations is completely English and digitized. So one needs to log into the platform. So the project deployed personnel, deployed support to get these registrations and transportation done. To figure out the measurement, the vaccination staff recorded each beneficiary's vaccination and entered the data in India's COVID database, as well as the project database, to enable measurement of the number of beneficiaries who were being served by the strategy. The project has also documented qualitative lessons that have been learned around. What you see on the screen is a picture of the Wellness on Wheels, the vaccine mobile unit that runs across different parts. So this is a picture of a tea garden area of Assam in Northeast India. Next slide, please. So at the outcomes, from this intervention, what has come out as impact and what have we learned? In 15 districts of Assam, where these units were deployed through these mobile vans, the demand generation community engagement interventions have helped reach more than 300,000 community members with the USAID-supported messaging on COVID-19 vaccination, including the elderly. The mobile vans have also administered about 10,000 plus doses for COVID-19 vaccine in these hard-to-reach scattered areas across these districts. And across 18 states in the country, the project has administered more than 6.2 million doses for COVID-19 vaccine. So key learnings, what has worked, what can be scaled and replicated for future projects and interventions. So strong ongoing collaboration with local governments and community leaders had helped to identify these hard-to-reach populations, pockets where the vaccination coverage was low, pockets where the people resided, the community members stayed, such as the elderly, and in identifying potential solutions to make the approaches work. Partnering with community-based organizations to devise contextually appropriate outreach strategies helped the project to identify and train volunteers, worked with NGOs that were embedded and trusted by the community, relied on local leaders in villages through self-help groups, and to increase strategies about the program that were being done. It was also critical to invest in non-traditional approaches of reaching hard-to-reach groups, such as mobile vans and transportation support. The elderly needed a wheelchair to be transported, that was provided. If they required a vehicle to be taken from their home, picked up, and to be taken to the vaccination site and transported back to home, that was also provided. Next slide, please. So what you see on the screen is this whole pledge board that when people have come forward to take up their vaccination, the elderly have shown a lot of interest and lot of excitement that when their vaccination have been done, and they've been proud and confident to show this off a bit with the project. You can see their pledge board signing this off that they are proud and they are happy with the ways vaccination has been provided. And the way these community engagement approaches have worked in speeding up the vaccination rate in the country and in the state of Assam. So currently India is at about a 98% vaccination status, which is fabulous with the first dose. And we hope to quickly reach all our eligible population. And with approaches that are now taking the vaccination to their doorstep, I think this would be a good way to move forward. So thank you all. Thank you for this opportunity.
Thank you, Anumega. Thank you so much for ending on such a positive note, despite working in such a difficult situation. It really shows, from all of the speakers, how much resilience sometimes comes out from us in the toughest of scenarios. So thank you so much for that. I think it motivates me, certainly, and I'm sure others on the call. I wonder if we can go on to the next speakers, please.
Hello, this is it's my turn, right, Shita?
Hello, Lily.
Okay.
How are you? Nice to see you.
I am really grateful for this opportunity to talk to you, and much more to Charlotte, and of course the Geneva Learning Foundation, which I joined just like March of this year. It was like a friend told me something about this Geneva Learning, and then I looked at it and it says immunization agenda, and I have been working on vaccines for such a long time, and yet this is the first time that I have heard about the Geneva Learning Foundation. And true enough, I joined because I wanted to really learn so much. And mind you, it was always midnight in the Philippines when I joined. And I just want to tell you what the Philippines is like. It is an archipelago where there is so many areas hard to reach. I have listened to so many of the speakers who said that indeed it is a challenge for the hard to reach areas to get vaccination there. But you know, in the Philippines, way back in the 90s, the midwives will cross dangerous rivers. They will climb hills and valleys just to reach those children. You started our EPI way back in 1976. And since the time on, vaccination has been at the forefront of child health. Unfortunately, the elderly, to whom I will address my topic today, has not been vaccinated so much, because if you compute, the elderly from 60 and above has not experienced that kind of vaccination, whereas the others, the younger ones, are used to it. So when I joined and I wanted to know more about what's going on, how does the immunization agenda, knowing that it is for everyone, everywhere, and every age to get the benefits of vaccine for good health and well-being. That was the motto of the Immunization Agenda 2030. So I really felt that I needed to learn more. And mind you, also, I've been doing vaccinology for such a long time. You know, I'm a pediatrician of 45 years and a vaccinologist for more than 35 years doing vaccinology, vaccine teaching. I'm a professor. But this Geneva Learning Foundation, actually, and I'm sure all the members here who are listening, I hope that you can really get as much from what Reda and Charlotte has been saying. Because for my part, and next slide, please, I'd like to tell you that I have been on social media trying to figure out how to really engage people. And then I suddenly realized that we do have people who have their problems. And so we said, well, why not ask some of the ordinary people to tell us their problems? And soon enough, we had an 85-year-old mother and a grandmother whose son came to us and said his mom is reluctant because he has heard so much about harm that is being given to vaccine, and she doesn't want to be vaccinated. But we all know that the elderly, even in the Philippines, have not been so much, concentrating on elderly, and yet they are the most vulnerable. They are at the highest risk of serious and fatal COVID. We know that. And they have to be the first one. In fact, our prioritization list says that the first priority should be the healthcare worker. The second one should be the elderly. But this mom could not get herself to be vaccinated, though he has heard from her son, and from her other friends, maybe. And so what the son said was, let's take you to the experts. And this is what happened next. Because then we featured her. She was scared. She has heard so many news about, there's going to be a myocarditis, Guillain-Barré from COVID vaccination. So she says, it's not gonna be for her. She has not been vaccinated, and she's not gonna, have her life be full of all this nonsense about vaccines. So next slide, please. So what we did, and this is very nice, we did have a kind of a podcast every Saturday, 7 to 8, since about the start of the pandemic, talking about, immunization and the impact in childhood immunization, because we're almost all pediatricians here. You see, we have 6 vaccinologists, vaccine experts, we have community pediatricians, a member of the National Immunization Technical Advisory Group, and even a member of the National EPI Manager. And we actually are the ones talking to people and getting experts to give their advices. But I realized that when I was listening to the Geneva Learning Foundation, I really thought that, yes, we should really listen to ordinary people too, not just health workers, because they know what they're doing, but the ordinary people don't. So here we have the grandmother, the son told us to, let's her be focused and the elderly was focused. And we talked to her and we said, you know, your son loves you so much that on Mother's Day, we featured her because it's Mother's Day. And you know, in the Philippines, let me give you another background. In the Philippines, we are very much a family-oriented type of population, extended family. Almost 80% are Christians. We have 15% Muslim population, and we are always, you know, mostly looking after the elderly. So this son who expressed to his mom that you should really talk to the experts. So then we focused on that 7 to 8 Mother's Day special. It was on the occasion of Mother's Day. You know, May second Sunday of May was the Mother's Day. And we sort of told her how, you know, elderlies are really going to be so vulnerable, so risky to have the COVID. What's the problem? And she told us, you know, yes, she hasn't been vaccinated before. She's not gonna use it. She's strong. She's active at 85. Why get vaccinated? You know. And so the podcast, the experts, all the EPI managers, these are community pediatrician. We have immunologists there. And soon enough, she says, okay, I'll think about it. The next thing we knew, and this is actually going to be so nice, is we heard from the son that right after our conversation the following day, oh no, not Sunday, Monday, because it was always Saturday. On Monday, we had that very nice news that the son told us she got vaccinated and so happy about that. On the following Saturday, we got her to come back and ask her what her experiences were. And she told us that, yes, it was so mild. There was nothing that she experienced. And we thought we were so happy, and we would always now feature this kind of conversation, listening to people, listening to what they have to tell us, so that in the long run, we may be able to encourage more people. Now, the fact is, since the 90s, the Philippines have always been high in immunization coverage. But something happened in 2018, when the dengue vaccine caused a lot of chaos and controversial issues that made mothers think that vaccines harm. And this is very unique to the Philippines. And some of you might remember that the dengue vaccine, which was first introduced in the Philippines, was so controversial. There is still a kind of a indictment for some of the health officials who introduced the dengue vaccine because they thought it was going to cause harm and cause death. And from a very high 93% vaccine confidence that the Philippines had in 2015, you know, in 2018, it went down to 32% vaccine confidence. And in 2019, we had the most number of measles deaths. And that was so disastrous because we thought, we, the vaccine advocates, thought that, you know, if we do not do something, if we do not restore the trust, if we are not able to address major aftershocks, those misinformation, disinformation, that some of those, you know, I don't know how you will call them. Are they really ignorant, or are they really the anti-vaxxers? Are they really the devils? We don't know. They say that's only 2%. But when things happen like this, it can really be disastrous. And the 1,000 deaths that we got from measles in 2019 is a testimony that you cannot let your guards down when it comes to vaccine confidence. You have to continue fighting misinformation and disinformation. Right now, we have from a 25% elderly vaccination way back in 2021 and going on, we now have 75% of our elderly being able to get vaccination throughout most of the national capital region. And so this is what is for us happiness. If you say what are the key learnings, yes, we felt that the love of a son cannot be discounted. A mother who knows that the vaccination will be an expression of love, will be an expression of concern and affection. To me, this is something that will also benefit our vaccination programs. Listen to them, listen to what they have to say, and address it with the experts in tow. Not just one, but 2, 3, or more experts will be much more kind of believable, because there are many fake experts that can only tell you, this much, and then they start the disinformation. So thank you very much for this opportunity, and thank you, Charlotte, for that chance to be here. This is like a laboratory for me. This Geneva Learning Foundation to me is like a hands-on. It is something that tells people globally to do something. And I agree. We have to spread the word that we can actually benefit from learning either from social media or listening to ordinary people. Thank you.
Thank you so much, Lulu. Great. I think I'm so honored to have been able to chair this session with all of you, with you five. The enthusiasm is amazing. I have seen the chat blow up, really incredible. Couple of remarks from me, and I will also perhaps challenge the speakers here today and perhaps some of the participants in my closing remarks, and when I hand over questions to you. I hope you will allow me to do it in a panel form as well, as there's some overlap. Today you have spoken to us about cross-learning, the South-to-South learning, about integration, about how you, with the partners who have organized this today, how you have engaged in various different levels and how they have supported that, particularly in some of the institutions you represent. We have heard nous avons entendu aujourd'hui le grand succès des vaccinodromes dans un temps très court, et comment ce succès a mené à une demande pour la vaccination du Covid dans des endroits qui n'auront pas l'accès normalement. Parler de comment le vaccin vient
Now we would like to know how we can be closer to people when we have to deliver, to reach people who have to choose between working or getting vaccinated.
Not only health education, health promotion, but the education system. We have heard from actors who are working in what we sometimes term fragile states, or states that are in transition, such as Syria, such as some parts of the DRC. So I wonder, and I will turn to all of you with some of the questions. Cynthia, I wonder if we can start. I'll go in the order of presentations. I wonder if we can start with you, and you can somehow detail us the COVID-19 prevalence in Syria, and also in your time in answering, what are the challenges in Syria and what mechanisms can you put into place to reach hard-to-reach communities? And also, it would be nice to have a resource analysis of how much and what it costs to implement a successful program in a hard-to-reach setting like Syria. And can you elaborate, and of course, to elaborate for some of our partners here on the cost of implementation. I think you have a number of colleagues who work in, shall we say, comparable settings, and how can they learn from your experience? Carla, une question semblable pour vous aussi. Quels sont les coûts en termes de ressources humaines et matériels que vous avez utilisés pour la mise en place des vaccinodromes, the cost in terms of HR and other materials that were used to implement the vaccinodromes in Kinshasa? I like questions sometimes on planning HR costs, because it means, is it transferable? Can we take it from one part of the world to another? So it's not just about learning, it's about cross-transferring your scalability. And is there a sustainability aspect? Another one for you, Carla. Let's talk about community health worker motivation to achieve this vaccine coverage. And this is perhaps relevant to all the speakers today. What exactly did you do for motivation and to convert that hesitancy into confidence? And the last one for you, how do you keep folk engaged throughout, considering some of the finer details that comes with some of these settings? Of course, you have early adopters, late adopters, people who want to wait in those settings and because of the considerations of the family. Charlotte, then it will be over to you. We've spoken about the by offering a digital method here of engaging. What's the equity issue? This often gets raised in low middle income country resource settings. How do you access the strategy of to better deliver on vaccine delivery? Can you also segregate for us today some various action plans and the different parameters, such as 1, resource availability, 2, the very important gender consideration. I will add youth to that, the key barriers and other challenges, including community engagement. Is there a package? We can have action plans. Anumega, you have spoken very clearly of the cross-district aspect of sharing and learning under your project. And you have also spoken to us about rural and urban preferences. How do we deal with those? Finally, Lulu, you have spoken very clearly about motivation, but also intergeneration. How do you, in this life course, how do you keep talking about it? So I'll be calling on you, and I will challenge you today before I close the session. A number of us are sitting, with policy implementers, with those who make the decisions. So what can we take today to go back? When I leave you today, what can I go back with to better mobilize funding for some of these aspects that could be transferred to other settings or that could be scaled in your own countries? So I'll start with you, Cynthia, please, and then call upon the next speaker. Thank you.
Thank you so much, Sheetal. So if I'm remembering correctly, I will start by giving a brief on the prevalence of COVID-19 in Syria. Well, this has been, and this still continues to be, a bit of a tricky question because when it comes to Syria and the numbers of COVID-19 cases, it is very hard to get a very accurate snapshot of what actually the situation is. What I can give you is that starting March 2020, from the beginning of the pandemic till now, Syria has around 56,000 confirmed COVID-19 cases and with around 3,000 associated deaths. And the testing rate for COVID-19 is 970 per 100,000 people. So this shows that the testing rate is very low, and this means that we cannot get an accurate representation of what the situation in reality is. So we keep on relying on the official data, but we know that we should take these with a grain of salt as they are not representative of what the actual situation is. Regarding the challenges when it comes to vaccination in Syria, in the beginning of the vaccination campaign in Syria, if I'm not mistaken, that started around in April or May 2021. The issue in the beginning was the lack of vaccines in the country. The vaccines were arriving in very low numbers. Teams were ready to create demand when it comes to vaccines, but there was the issue of, okay, we create the demand, but we don't have vaccines to complete that cycle. So this was one of the main issues. Other issues were not being able to provide an appropriate cold chain for the vaccines, especially when it comes to reaching the vaccines to some of the areas where with the existing problems of fuel shortage, of electricity cuts, that has been showing a lot of, that has been making things very difficult, as well as vaccine hesitancy has been a main issue among health workers and the general population when it comes to, and the main reason for that was a lot of suspicion and fear of side effects and the sources of the vaccines. The mechanisms that SARC used to reach communities living in hard to reach areas that proved successful was actually investing in local resources. The main competitive advantage that SARC has is that it's an organization. It has that relies mainly on people coming from the communities and serving their communities. And one of the flagship programs at SARC is the community-based health and first aid, known as CBHFA. And this program mainly relies on people from the communities who are trained by SARC to act as focal persons and resources when it comes to health and social issues in their community. So this has been very key in gaining the trust in the communities that SARC was trying to reach, and also speaking to people in their own language, addressing the issues that they are also facing in their own homes. So this made the reach and access much easier. And the third question regarding cost, the good thing in this is that CPHFA and this approach is a very low cost approach, if we might say, when it comes to financial resources. It is time consuming, it requires a lot of time and effort, but because SARC relies on volunteers and health promoters who are not paid and who are doing this solely to serve their communities, so the cost of this project was very low. Hope this answers your questions. Thank you.
Thank you so much, Cynthia. Over to you, Carla, s'il vous plaît. Ils ont demandé sur les précisions, juste pour un rappel des coûts humains aussi, et la motivation, bien sûr.
So, of course, we need to take care of motivation, which is very important, how to change this hesitance to make people really trust the vaccines. Thank you. Thank you very much for these questions. Regarding the cost, that depends on human resources. Can you hear me? Okay, I'm sorry. So the cost depends on human resources available. For us, it was our first action. There were many factors we had to take into account. For example, there were different types of vaccines available. And in the beginning, we wanted to have several vaccinators in the centers for different types of vaccines. And then we had a team and different members who were doing different tasks. They were registering the information. They were preparing the certificates, so vaccination certificates. So that is to explain you how many personnel we needed. And then at a certain level, we understood that some personnel were very tired, and practically every day they had to work. They had to work 7 days out of 7. See, we take into consideration all the human resources we need. In this rotation of human resources, today we range around 100 people per site, and so the costs are quite reasonable. There are other things. We have improved certain other aspects. For example, we needed tents. We needed a lot of materials, different tools. We could reduce our costs on this. We have worked with WHO, which gave us some tents, so we didn't have to pay for the rent. And so everything depends on human resources, how many people are working. For example, if you need a special place to start vaccination. It depends on this too. Sure. In the what was the motivation to get vaccinated? At the beginning, I was hesitant too, and thanks to the training we've had, even then we had some hesitation after that, but thanks to sensibilization, thanks to all this information, we've learned things, and especially the first days, during the first days, we understood that the people, it was difficult because the people were asking us, are you vaccinated yourself? Why do you want us to get to be vaccinated? And then we started to use vaccination cards at a certain moment. It was a means to encourage people to get vaccinated. Concerning other motivation, of course, certain activity are not paid. And of course, when we ask people to work more, and they are not very much motivated in that case. And of course, that is something that needs to be taken into account. So we have been able to use different primes to motivate people and some other strategies to get them more motivated. Thank you. Thank you very much, Claire.
The additional method of engaging in the equity, and perhaps if we can also touch just a small reminder on the different parameters and how do you segregate those action plans according to gender, the key barriers and other challenges from community engagement, and maybe an action plan options for some of our colleagues on the call today. Thank you.
Thank you so much, Shital. Those are great questions. And I'll start with the hackathon methodology. First and foremost, it can be deployed offline. So it's most of that is 80% of the participants felt that they were capable of applying that methodology with their teams on an offline basis. And so we're actually focusing on district managers and supporting them to be able to implement that methodology with their team. And also in the last 3 years, we have noticed we moved from 3% participation, less than 3% participation of health facility staff, that is frontline staff, to over 30% recently. And you saw from the slides I showed earlier that over 70% of our participants were from district and health facility levels. So you see that the use of the digital space, internet connectivity, is actually increasing. And finally, I think motivation, you asked about motivation. I think motivation is really the key. And we have seen participants share with us that they had to travel over 400 kilometers to access internet connectivity so that they can participate in the sessions. But one thing I'd like to highlight is that there is 80% of the work is done offline, 20% is actually online for experience sharing and feedback and all of that. So that is it. And then concerning the question on equity, actually on the parameters, actually this has been done by the Côte d'Ivoire team upon request of the National EPI and the National Institute of Public Hygiene. So the alumni team, that is the group of former scholars of participants in our program, they developed their own evaluation report and worked with the National EPI to review it and identify plans that are most promising. And we are continuing to track the implementation of this plan. And recently, I just learned that the leader of the alumni team has been invited to join the national COVID response planning session that is coming up in Cote d'Ivoire. And Gavi has also reviewed the plan. So perhaps one idea may be to share the lessons learned from this review with partners if this hasn't already been done or established through the channels that are available. And one thing I also said is, even during the hackathon, there were participants from 20 other countries that came to assist. And at the end of it all, most of them were requesting that they would like to have the same thing organized in their own countries. And one example that I can cite here is DRC. So we have many other countries that express the need if they could get the hackathon organized to accelerate COVID-19 vaccine uptake. So the only issue is resource limitations. So I hope I've answered all the questions. Thank you.
Thank you so much, Charlotte. I'm also keeping an eye out for time for the next for closing. So I wonder over to you, Anumega, about some, and please feel free to touch on some of the issues because they are, like previous speakers' questions have been, because I think they're also relevant across the board, and maybe some top line things for us to take away from the work you've done. Thank you.
Right. Thank you, Sheetal. So Sheetal, when you're working with the community like elderly citizens across the country, not just northeastern state like Assam, but even across the country, I think a few top line questions and challenges that all of us faces, the elderly citizens suffer with a lot of comorbidities. So, building the confidence that this vaccine will not compound your existing medical ailment. It will also work in support to it. It will not just compound it. That's very important to drive as a message. In many sessions, we also the project took a doctor with them so as to answer the questions there and then. In a few instances, we also took a few other vital parameters, check equipment, so that people feel a little confident, and proper AFI management setups were done, so that in case of senior citizens, when you work with them, you have to be prepared for all. And the elderly citizens can actually get away by just a nice way of, a scolding to the team, and they can just walk away with it in a very sweet way. So I think that was an integrated approach. And when you have these mobile vans going, so it's not just a van as a very physical metallic thing going. It has people who worked a little before that, when the van parks itself, to raise demand, to spread the word about that the van has landed, and why all of this needs to come together. Community miking is put out, street plays like Nukkad Natak, as we call it, that's undertaken at the ground level. Engagements are built around so that people are well aware about it. And this entire support of tapping in community, local leaders also helps us because they enjoy the credibility and influence in the community. So the idea was to move quickly on the scope and scale. So when you have a few more advocates talking about you, the job becomes a little simpler for the teams to move in. It's about breaking these behavioral barriers and moving as fast as one can. So I think these few top line things have really worked for the project. And John Snow India has been implementing this project under the USAID Momentum flagship grant. So I think it's been a great learning experience for all of us, and happy to share it at this forum. Thank you.
Thank you, Anumega. And I share a number of colleagues there who are vaccinating the USAID initiative that has, really tapped into like the grassroots level issues up to the top and those populations that are prioritized. So thank you so much. Last but never least, Lulu, please, looking forward to hearing some intergenerational lessons that we can all take, particularly as a lot of our cultures have similar aspects. Thank you, Lulu.
Sheetal, I'd really want to say just two statements. What works well is actually the commitment of group of experts, health workers, who will educate even policy makers on the basis of good science and data, evidence, and to show the empathy, the compassion, the love. Vaccination is love, an act of love. That was said by our Pope, Pope Francis. So this is something that I think everybody could learn from. And with this act of love, I think everybody else with transparency, empathy, compassion, listening. This will work well. Thank you.
Wow, Lulu, very, very strong message for us all to end. I have come away with some important messages from you all. This community aspect, this in the resource in the context we live in, and how we can adapt that. I think also very important is, we speak as organizations sometimes who are there and who have strategies and mandates and funding for a certain amount of time, but they are institutions that are there for much longer. Is it the church? Is it the mosque? Is it the literacy campaigns? Is it the savings group? And some of you have touched upon some of those ideas that work, or some of the small and medium enterprises that work. So I have been very invigorated by that. So thank you so much. I have seen in the chat there is a very important, and I will also put my hat in the ring for this request. Can we have a recording that is easily available? Is there a community of practice we can start turning to? So many times we want to know, well, what worked for you, and is it accessible? Sometimes it's about how it is presented in the format, with the technology, with the language. Is it accessible for us? As you know, we're sometimes on such a touch and go basis in some of these settings. And of course, it's evolving, not only with the demand issues, the supply issues, the variant issues, and how some of it is impacting, of course, the health workforce and the communities that serve. So that one request, so how can we grow this community practice, and how can we make it more accessible, easily accessible? I will be looking forward to engaging with it and then taking it back to all the levels I work with and engage and advocate on these important issues. Very big thank you to the presenters. Congratulations, keep it up. I think you stand on shoulders of giants for people who have supported you in this work. I wish you very well and continue this work. And I also wish you a good session tomorrow. I can hand it back, and I see Lisa Manning will be doing closing remarks for today. A very warm hello to you, Lisa, and always a pleasure to be with you in these sessions. Thank you so much, everyone, and we will be speaking soon.
And thank you so much, Sheetal, for your contributions and wonderful facilitation today. Just done a great job, and being able to cover that in English and French, and no less. So many thanks. And many thanks as well to Dan Irvine from World Vision, who facilitated the previous session. And also a huge thanks to all of our participants. All of the energy and ideas, questions and comments has just been so motivating and inspiring for all of us. And it's been great to see you share all of your own reflections and thoughts and some of your experiences as part of this discussion as well. So thank you to everyone who joined us today and for all of your contributions. I'm not sure I'll even endeavour to try to summarise all of the important ground that we've covered today. We started with our high-level roundtable with a perspective on the importance of political commitment and leadership and ways in which that can be demonstrated. We then went into our sessions on the technical areas, firstly on facilitating behaviours and behavioural interventions, and then most recently bringing services to the communities. And I think some of the most important things that have stood out for me, firstly, the importance of engaging with communities. And as part of that, really truly understanding reasons why there's low uptake, or understanding why there's hesitancy and the underlying reasons. And local data collection is really an important part of that. And then, of course, a co-design process with communities themselves in the design and implementation of the various strategies. And what has also stood out for me is the importance of multi-component strategies. Throughout all of the presentations today, there's been examples given of strategies or interventions that not only consider ways to make access easy and convenient and truly affordable, bringing vaccines to the communities themselves, the last mile delivery, thinking about situating vaccination in vaccinodromes and through events and other types of strategies that really just make it so easy and convenient for our prioritized populations. And so combining those delivery strategies with the role of community health workers and the importance of information that's shared through trusted messengers and other local partners. And beyond that, even, for example, the use of requirements and ways in which that also helps to move vaccine beneficiaries to action. So it has just been an incredibly rich and inspiring discussion. We've talked about not only these interventions, but other cross-cutting themes like data, costs, human rights, equity and gender. So this has really just been, you know, an incredible moment. And I really do hope that it helps to respond to the urgency that Ted Chaiban outlined in some of his remarks at the start of the day, and really just mobilizing this moment that we have right now to act and to really think about our prioritized population groups as well. So I will leave it there for now. A huge thanks again to our speakers, our participants, our facilitators. Also a huge thanks to the partners who've helped in planning this entire event. UNICEF in particular, who have just managed a huge lift over the last few weeks. And we're not over yet. So tomorrow we come back at 7 a.m. Eastern Standard Time, or that's 1 o'clock Geneva time or European time. And we will have our next 2 technical sessions. And those 2 technical sessions, the first will be on misinformation and responding to rumors and thinking about the information environment. And the next will be on community engagement. And that's really at the heart of it. It's thinking about our end users and the people whose needs we really need to respond to. So really looking forward to tomorrow, and thank you again to everyone, and see you then. Thank you. Bye-bye.
Thanks, everyone. Take care. Bye.